And this is also a very important moment of time. I may recommend this Congress or the coming Congress to consider giving space for this very important national initiative to see after 2 decades where we can go in future. With that, I hope everybody will enjoy it. I hope the international guests will be here in Kingdom as soon as possible, inshallah, with the ease of all the restrictions, inshallah, will we go in recovery after this pandemic. Thank you very much. Thanks for the organizing committee. Thanks for all participants and speakers. Thanks, Dr. Firas Al-Freih, for the kind invitation and amazing organization. Thank you very much. Assalamu alaikum.
Thank you, Prof. We appreciate your participation. We'll move to next. Now it's my great pleasure to introduce Dr. Riyad Al-Faqih. Dr. Riyad is the head of the research department in King Faisal. He's an associate professor in hematology and bone marrow transplant. Dr. Riyad is the scientific chair of the malignant hematology session. Dr. Riyad.
Assalamu alaikum. I'd like to welcome everybody, and hopefully you have a fruitful meeting. Will not take long, just to get started. So today we will have 2 sessions about malignant hematology, and tomorrow we will have the same, inshallah. The first session today will be moderated by Dr. Firas. You all know Dr. Firas, the head of the Saudi Society of Blood Disorder and a consultant at King Faisal. So he will be moderating the first session. And the second session will be moderated by Dr. Syed Usman Ahmed, a hematology consultant at King Faisal Specialist Hospital. Each session is 3 talks and 15 minutes for questions and answer. Each talk is 25 minutes. And in between the sessions, we will have 15 minutes break. That's at 16:50. So from 16:50 to 17:05, we will have a break. And then the second session will resume. We do have a virtual exhibition. We encourage all of you to visit and visit the booth of our sponsors. We thank our sponsors to make this meeting happen in the middle of this pandemic. Without any further elaboration, I would like to leave the floor for Dr. Firas Al-Freih to start the first session. Firas.
Thank you, Riyad. So it's my great pleasure to introduce Dr. Wendy Stock. Dr. Wendy Stock is a renowned physician, scientist, educator, and in leukemia in general, and specifically in acute lymphoblastic leukemia. She's a professor at the University of Chicago. She has more than 200 peer-reviewed papers. Also, she's receiver of several awards as a researcher, as an educator, as a top doctor, physician. Without a delay, so she will be talking today on the current trends and advances in the frontline management of acute lymphoblastic leukemia. Dr. Wendy, if you can unmute yourself. I would like to remind the audience, you can type the questions and we'll try to address them at the end of the session. Thank you. I saw that. Dr. Nicola Gobudget is a professor of hematology in Frankfurt University, Germany. She's a leading investigator in several important papers, including blinatumomab. She's also the first author of several hundreds of papers. Without any further delay, Dr. Nicola, the floor is yours. Maybe you can share your screen, your presentation, please. Thank you.
Yeah, hello. Do you see my presentation?
Not yet.
Okay. Now?
Not yet. May I ask the administrative staff to maybe try share from
Let
there?
me try again. I try again.
Let's try one more time. Let's try one more time.
Oh, something happens. Yeah.
I see it's. I see it is loading. Screen share has started.
Yeah.
No.
Do you see it now?
I do see it now. Yes, it's clear. Thank you.
Okay, so I can start. Yeah, thank you very much for the kind invitation. It's a real honor to participate in this session. And also congratulations to all your activities in Saudi Arabia regarding the management of acute lymphoblastic leukemia and other hematologic diseases. It's my pleasure today to speak specifically about the management of MRD positive ALL. And I do this mainly in my role also as a leader of the German multi-center study group for adult ALL, in which more than 150 hospitals participate, and therefore I know the networking issues very well. These are my disclosures, and I would like to start with a few definitions about MRD. So if we have blasts above 5%, clearly we have hematologically or cytologic relapse or failure of the disease. Between 5% and 0.01% is usually the level where we have quantifiable MRD. So most methods for MRD detection have a sensitivity of about 0.01%. Now below this level, with some methods, we have the option to detect also MRD on a low level, sometimes also not quantifiable MRD. So this is a kind of intermediate MRD situation. And then we have a MRD negative status, which actually means non-detectable MRD. And we know that the relapse risk is very high for patients who remain after the standard therapy MRD positive above 0.01%. And we know that patients who are MRD negative have usually a very good prognosis and a low relapse risk. For the intermediate patients, we don't know the risks very clearly, and I will come back to this issue a little bit later. Now, I think everybody knows that the MRD persistence is very strongly correlated with outcome in pediatric ALL and in adult ALL on the right side. This is the strongest prognostic factor for both diseases, and patients who remain MRD positive nearly all relapse despite continuous treatment, and their overall survival is also very poor, as shown here in this large meta-analysis. It has also been shown by other meta-analysis, here a more recent one by Renato Bazan, showing that patients with persistent MRD have always a strong prognostic impact on the overall survival. So based on these data, clearly we need to analyze MRD in all ALL patients. This is one of the most important diagnostic procedures, and we have different techniques available. I don't want to go into detail for that today. Maybe we come to this in the discussion, but it's very important that we need to standardize these methods. We have to take the shortcomings of different methods into account. For example, maybe a lower sensitivity with flow cytometry. This is one of the issues. Or, for example, the longer time to receive results with a PCR-based method. And what is also very important is the reporting of the results. An MRD report should always include the level of MRD and also the sensitivity, particularly when the MRD result is negative. And we have very clear definitions now implemented in the German ALL group for the failure and the relapse on the molecular level, on the MRD level. So we speak about a molecular failure if the MRD is above 0.01%. And we speak about molecular relapse if a patient is first in molecular CR and then comes back with MRD positive status. And these definitions are used in the trial and also used for decision making on treatment modifications. And therefore, the clear definition is very important. Now, another issue is which time point is most relevant for treatment decisions. And this depends certainly on the different protocols. What I can say from our experience is that when we have a very early time point, and this is, for example, day 11, this is only after vincristine, dexamethasone, and 2 days of daunorubicin in our protocol. If a patient is MRD negative very early, as shown here, the prognosis is excellent. However, only a very low number of patients, less than 10%, come into this very favorable subgroups. On the other hand, at later time points, this is here week 16, which is after induction, 2 phases, and the consolidation treatment, if a patient then remains MRD positive, the outcome is very poor. So early negative is excellent prognosis with continued treatment, and late positive is poor prognosis despite continued treatment. So the optimal time point for decision making depends on the planned consequences. Here you can consider, for example, treatment reductions. In the positive patients, treatment intensity.
Dr. Nicola, you are muted.
I try to unmute.
Yes, I hear you now.
Okay, yeah, sorry. Okay, so level of MRD is important as well. And I show you here the European meta-analysis, which indicates the correlation of MRD level, better prognosis with lower MRD levels compared to the poorest prognosis in patients with high MRD levels. And on the right side, you see here the differentiation for patients with MRD below or above 10 to the minus 3. So clearly, the higher the MRD level, the shorter is the interval to the forthcoming hematologic relapse. But what about the intermediate MRD levels? We have analyzed this in our data set, and as we can see, about 60% of the patients after induction therapy have a molecular CR, and the overall survival of these patients is excellent. There are a few patients who are MRD negative, but the sensitivity is not sufficient. Again, these patients have an excellent prognosis in terms of survival. Then we have the molecular failure patients, 18% of the total population, and their overall survival is very poor, mostly due to relapses. But patients who are low positive, so below 10 to the minus 4, or non-quantifiable, they have an intermediate prognosis. So the overall survival is 68%, remission duration 76%. So I think it's very important to know the exact MRD level, and not all types of MRD positivity mean the same for the prognosis. So this brings me to the treatment options. And first of all, in patients with an excellent prognosis, I've shown you those patients who already are in molecular CR after the first days of induction therapy. Here we could consider a de-escalation of treatment, which has been tried in pediatric ALL in some trials. And I think we must be very careful with that. On the other hand, the biggest problem which we have in adult ALL is actually the group of patients with poor MRD responders. And what was tried in this patient population was to intensify standard treatment. And I show you here some data which we have generated in our German ALL group. If patients with molecular failure were treated with high-dose methotrexate asparaginase, and this indicates a 24% additional molecular remissions. Also, other chemotherapy cycles indicate very few additional molecular remissions. So we can understand from these data that the use of further chemotherapy does not help in these patients usually because they are somewhat chemotherapy refractory. So the next approach, which was considered in these patients, to offer them immediately a stem cell transplantation as the most intensive treatment which we have available. And I also don't want to show many data on this, but only a summary table that patients with a high MRD level before the stem cell transplantation have a poorer outcome after the transplantation. So transplantation is certainly a good idea for these MRD positive patients, but not optimal if it's done immediately in the high MRD level situation. And this brings us to the idea to use alternative compounds in these patients with different mechanisms. Yeah.
We lost your slides. I don't know if you can reshare.
Oh, sorry, I don't know.
Just now.
Is it available now?
Not yet.
Okay.
Okay, it's loading now.
I don't know why this happens, but I'm sorry.
Sorry about that. Oh, sorry.
So, do you see it now?
It's loading, so I think it's coming.
Mm-hmm. Do you see it?
Not yet.
No, I don't know what else I can do. Because I see it.
Professor, I can see your slides. All right, please. I can see your slide. Put in slide mode. And now it's working for my side.
You can see it? Okay. Okay.
Okay.
I can see it too. Yeah,
okay.
You can go ahead.
Good, very well. So, so as I said, the situation in the MRD positive ALL, which are chemotherapy resistant, brings us to the idea to use compounds with different mechanisms of action to reduce the MRD load before the stem cell transplantation and also to maintain the remission in patients who are not candidates for a transplant. And in ALL, we have, beside pH positive ALL, very little options for molecular targeted therapies, and therefore the immunotherapies are very important. Which are rituximab, part of this, in many protocols already part of the standard of care, inotuzumab, a CD22 antibody, blinatumomab, and also the CAR T cells. Now, blinatumomab was used in different settings in the relapsed refractory setting, and this is a summary of the data here, showing that the CR rate in the full relapse is always around 40%, 43%, and the median overall survival in this situation is rather poor. It's better than chemotherapy, but we cannot be satisfied with this outcome. And therefore, the consideration came up to use a compound at lower MRD levels in MRD positive patients and not in the full relapse. And we did a small pilot trial in Germany with blinatumomab in MRD positive ALL, showing in 20 patients a quite favorable overall relapse-free survival, 80% response after only one cycle, and very few patients remained long-term remission without further therapy. And there's also a long-term follow-up of this trial showing that a number of patients remain in long-term remission. All the long-term survivors had achieved MRD negative remission after the treatment of blinatumomab. Some of them were transplanted, a few were not transplanted. And based on these very, very promising data, we decided to perform a larger international trial, which was an Amgen trial, in MRD positive ALL above 10 to the minus 3, the MRD level, so a rather high MRD level. And patients were included in first remission MRD positive, but also in later remission. 35% were MRD positive after a prior relapse. Overall, 100 patients were included. And as in the pilot trial, 78% of the patients achieved a molecular remission after one cycle of blinatumomab. And as you can see on the right side, there were no entry criteria like age or remission status influencing the remission rate. So in all subgroups, the response rates were very good. Importantly, in the MRD setting, we don't do a dose step. So in MRD, in the relapsed refractory setting, blinatumomab has a dose step after 1 week. In the MRD setting, we start with a high dose already at the beginning. The overall survival on long-term follow-up is shown here, 36 months median, which is very favorable, particularly if you compare it with the relapsed refractory setting. Patients achieving a complete MRD response have an excellent outcome compared to those who don't have a complete MRD response. So it's a clear advantage for the patients responding. And this is already after 1 cycle. Comparing patients treated in CR1 and in CR2, you can see that the patients in CR1 have a better outcome, but also the patient in CR2 who remain MRD positive after a salvage treatment can benefit from the additional use of blinatumomab. Now, one of the most important questions which we try to address in discussions about this trial is the question whether we need a transplant in patients who are treated with blinatumomab in the MRD setting and achieve a response. And these are the blue curves here. On the left side, you can see the patients who have been transplanted after achieving a molecular remission. On the right side, the patients who are not transplanted. And on first sight, those curves don't look much different. But there are differences behind that. And the most important difference is that these are very, very few patients who were not transplanted. Overall, 70% of the patients had received a stem cell transplantation. And there are more differences. For the transplanted patients, we see that it's a quite high median age of 42 years. Most of the transplantations were unrelated. 34% were mismatched transplantations, and despite the higher age, most patients had a myeloablative conditioning regimen. And from these characteristics, we can anticipate that there's a higher risk of transplant-related mortality in this patient population. And this actually also happened. You can see here the outcome in green for the patients who had received a stem cell transplantation after blinatumomab, and in orange, those who were not transplanted. And the major difference is here that with transplantation, more patients stayed in continuous complete remission. On the other hand, most patients who were not transplanted relapsed. The problem in the transplanted patients is the relatively high transplant-related mortality, which was here 36%. And I have mentioned the potential reasons for this problem. Some of the patients who did not receive a transplant received a transplant after relapse. So even the patients here considered as no transplant had a transplant in a later time point in some of the cases. So overall, we have the dilemma. The transplanted patients have a high mortality and probably suboptimal transplant procedures, as shown before. The non-transplanted patients have a higher relapse risk, and because they had no standardized follow-up treatment. A solution can be different. So we should avoid probably high-risk transplant procedures in patients who respond to blinatumomab and evaluate dose-reduced conditioning in these patients. And in the non-transplantable patients, we should do the MRD follow-up and also a consolidation and maintenance therapy. So overall, blinatumomab in MRD-positive ALL has a high response rate. There is no dose step, which can be a reason for the good outcome also. The good tolerability, a benefit for the responders, and much better results compared to the relapsed refractory setting. And we also compared in the historical comparator analysis with standard care therapy, blinatumomab, and this also confirms the advantage of this treatment approach, which we currently also use in our first-line treatment. Now the question is whether this is already standard of care. And I think this is a recommendation from the North American expert recommending in MRD-positive patients with B precursor ALL 2 to 4 cycles blinatumomab and then an allogeneic transplant. Maybe we can a little bit more differentiate the situation sorry, I go back one slide. And consider here for MRD positivity the MRD level, because not all MRD levels lead to a stem cell transplantation. I've shown you before that patients with low MRD have a intermediate prognosis. So this is something we should consider. And so in our group, we do the induction and consolidation, and in standard risk patients, according to the criteria like white blood cell count or molecular criteria, we continue the standard treatment if the patients are MRD negative, and if they are positive above 10⁻⁴, we give blinatumomab and then a transplant. If they are low positive, we try a targeted therapy, but then continue with standard treatment. And there's a similar approach in the high-risk ALL. Now, we have continued to analyze blinatumomab in the MRD setting, and in our trial, we have, in the meantime, 65 additional patients. The overall molecular response rate is 80%, so as in the BLAST trial and also in the pilot trial, the response rates are very good. The overall survival is also about 70% at 3 years, so very favorable. I would like to mention one point which can be important also for the further use of blinatumomab. And what we have seen here on the right side is that patients who do not achieve a complete MRD response after blinatumomab, so these are the green patients, molecular NA means low positive, they apparently have a trend to a little bit poorer prognosis, and therefore we may consider in these patients who remain somewhat MRD positive in after blinatumomab therapy additional treatment approaches. Also in the pediatric setting, it has been demonstrated in a real-world data collection that patients with MRD setting, so blast counts below 5%, have an excellent prognosis and response rates, and compared to those patients who have a higher blast count, and which means a full relapse. So the best setting to use blinatumomab is certainly the MRD setting. And this brings me to another pediatric trial, which has been discussed a lot in the past weeks and months with blinatumomab in the high-risk relapse. Hello? Do you hear me?
Yes, we hear you.
Okay. And in this trial, the patients with high-risk relapse had induction, consolidation, 2 cycles, and then they were randomized between blinatumomab and another chemotherapy cycle. So actually, this is an MRD trial where blinatumomab is used in the MRD setting. And as shown at the ASH meeting by Franco Locatelli, all of the patients were actually in the MRD situation when they received blinatumomab. And this trial showed a significant advantage in all endpoints for the use of blinatumomab compared to this additional high-dose chemotherapy cycle. So again, another confirmation that at least one cycle after prior chemotherapy can be replaced by blinatumomab with a big success also in terms of toxicity. Also, the trial by Robin Foer and colleagues in Ph-positive ALL, published in the New England Journal of Medicine, is an MRD trial. So here the patients received steroids and dasatinib, and then they received 3 to 5 cycles of blinatumomab together with dasatinib. All patients, 98% were in CR at this time point, only a few patients, 10% in molecular CR. And therefore, this is an MRD trial in Ph-positive ALL, and with additional blinatumomab cycles, the percentage of molecular responses increased by each cycle, although not all patients achieved a molecular response. Overall survival, it looks quite promising, but I think that a further follow-up of this trial is required because in Ph-positive ALL, we really need long-term survival data. Now, what about the CAR T cells? Also here, you have often the situation that the patients are included in the trials in the full relapse, but in the time point when the CAR T cells are given, they have only MRD. So this is shown here in this trial by Park and colleagues that nearly half of the patients were only MRD positive at the time point of infusion, and half of the patients had still a relapse situation. And you can see from the curves here that in the MRD setting, the outcome data were much better than in the patients with the higher disease burden, meaning a full relapse. Also, the real-world data of the CAR T-cell consortium show a similar picture. The overall survival and the event-free survival is much better with lower disease burden compared to high disease burden, again, defined as the MRD setting compared to full relapse. So also for the CAR T-cell, the MRD setting appears to be a favorable treatment situation. And this brings me to summarize that a standardized MRD assessment and reporting is essential. The best time point is after an adequate standard therapy. The MRD level is essential for treatment decisions. The targeted therapies are most promising because the patients are chemotherapy resistant. For the moment, we be careful with treatment reduction for patients with good MRD response. And there are a number of open questions, for example, whether we need a stem cell transplantation after an immunotherapy in MRD positive patients. And we also do not much about the prognostic impact of MRD after a salvage treatment. So thank you very much for your attention, and I hope that the technical problems were not too disturbing.
Thank you, Prof. Gokbajit. Outstanding talk. I would remind the attendees, kindly type your question and ask question button. So we'll move to the next talk by Professor Wendy Stock. I have already introduced to Dr. Wendy, who we were off the platform. So Dr. Wendy will be talking about the current trends and advances in the frontline management of acute lymphoblastic leukemia. So we'll have your slides up by the team.
Thank you very much.
And then we can start.
Is someone uploading my slides?
Yes, I think.
Thank you so much. Can you hear me now?
Yes, I can hear you.
Okay. Thank you so much. I'm so sorry about my technical incompetence. And thank you all so much for inviting me. I hope I'm a better doctor than I am a slide operator. Today is my pleasure to speak to you about the changing dynamic in treatment of ALL. And I so appreciate Nicola's beautiful talk just before mine, so that it will kind of complement, I hope, what I'm going to be saying. These are my disclosures. This is the summary slide showing you overall outcome in the past decades for adults with acute lymphoblastic leukemia in the United States cooperative groups. And what I wanted to highlight here was that we are moving forward. You will see in the next few slides how these survival rates, I hope, are going to really improve in the next several years and have already improved quite a lot. One of the ways that things have gotten so much better are the intensification approaches that we've used in the young adult population, sort of adapting more faithfully the treatment that is used in the pediatric population. And the adoption of these pediatric regimens faithfully with high doses of and frequent dosing of asparaginase, glucocorticoids, vincristine, and intrathecal therapy have been a key to the improvement in survival for our young adults with acute lymphoblastic leukemia. We have found that these regimens are feasible, that they are associated with low treatment-related mortality, but the toxicities are still significant, and they do increase with age. While they are manageable, they're still a significant problem, and that's something that we're working on. The major improvements have been made, however, in event-free and overall survival compared to historical controls, and now routinely reach more than 70%. This has really become a new standard of care for our younger adults with acute lymphoblastic leukemia. And I will show you on the next slide some of these results. This is a risk-adapted approach that was taken by the NOPFO group a number of years ago. This is a beautiful study that was published looking at an identical treatment regimen that is stratified by treatment response, not by age, and resulted in outstanding survival, as you can see here, for all adults and children who were enrolled on this trial. And this, again, was the identical treatment regimen given to all patients. The treatment was a little bit different based on basically minimal residual disease, suggesting treatment sensitivity after induction. This slide shows our data from the Cancer and Leukemia Group B, showing our change in outcome when we faithfully replicated an intensive pediatric regimen for patients ages 16 to 39 years. And compared to our historical controls, where our survival for these patients was only 46%, we now have overall survival rates, again, of greater than 70%, 73%. And this replicates what was found by the pediatricians in a younger patient population many years ago. So we are moving forward in our treatment for young adults with ALL. And as Dr. Gokbajet just beautifully outlined, minimal residual disease eradication should be our goal. And here are our data showing that disease-free survival, when you achieve MRD negativity after only induction therapy, is outstanding. 85% disease-free survival with no late relapses compared to those patients who remain MRD positive, whose outcomes are not as good. And now, as shown to you by Dr. Gokbajet, we have strategies where we are now employing new agents to try to eradicate minimal residual disease early and prevent relapse and emergence of resistant clones. Unfortunately, it's a challenge because only 40% of our patients are in this category at the moment after induction therapy. So we have to get the majority of patients here into this category. And how are we going to do it? Well, I just told you that further intensification using agents that we already employ is probably not going to be feasible. And you can see here on this slide in a recently published manuscript from Dr. Advani and colleagues reporting on outcomes for patients on the CALGB 10403 regimen. You can see that the different toxicities that are associated, for example, with asparaginase in particular, become higher even within the 16 to 39 year age group as one ages. And so further intensification is probably not the way to go because these toxicities are significant and impair our ability to move forward in a unified fashion with these patients. So how are we going to move forward? Well, Dr. Gokbajit already gave you a beautiful presentation on how this is going to be possible. And one of the ways we're focusing are on the use of the new antibodies in treatment. Dr. Gokbajit already went over some of this data. This is the TOWER study that resulted in approval of blinatumomab in the relapse setting for adults with ALL. And you already know these results. I'm going to just move on to this slide, showing that even in the relapse setting, as Dr. Gokbajit already showed you, the response rates were quite good and much better than anything that we've had in the past. This is in comparison to standard of care. And these are the true CR rates here.
Dr. Wendy, you are muted now.
Oh, I'm sorry about that.
Yeah, I hear you. I hear you now.
Okay, apologize. I apologize for that. I must have clicked it. Again, my technical expertise is lacking. This is the inotuzumab study that resulted in approval of inotuzumab for patients with relapse disease. And again, very similar to the TOWER study compared to standard of care therapy in the relapse setting, and resulted in extraordinarily, I'm not able to advance my slide now. Could you advance the slide for me?
Mr. Ayman? Anyone from the technical?
Here, perhaps. Oh, there, I got it now. I'm sorry. Excuse me. Don't know what happened there either. But you can see here that, again, extraordinarily high response rates and, importantly, high MRD negativity rates have been achieved in the relapse setting. So this brings us to the idea, as Dr. Gokbajit already showed you, that we can use these novel antibodies, which are quite well tolerated, in perhaps the frontline setting to achieve early eradication of minimal residual disease and improve event-free and overall survival. And these agents are now being built into frontline therapy, as already showed to you. In the United States, the trial that we're doing in the young adult population to try to achieve even improved outcomes is this trial, AO41501, including, again, younger adults with ALL up to the age of 40 years. And again, it is really a study that takes the 10403 regimen and expands it to include the addition in a randomized fashion of inotuzumab ozogamicin to try to achieve that early eradication of minimal residual disease and improve event-free survival. And our goal is to improve event-free survival from 66 to 80%. The trial has already accrued more than 50% of patients, so we're hoping that within the next year and a half or so, the trial will be fully accrued, and we will begin eventually to see some results. What I can tell you is that this addition of inotuzumab to frontline therapy has been very, very well tolerated. And here is another schema showing you this regimen again with the addition of inotuzumab in the front line in a randomized fashion. Now, I already showed you that there is toxicity when we try to use these pediatric regimens, even in the older, younger adults. And there have been a number of studies to try to determine what the age limitations are to this intensive pediatric approach. This is a publication from the French group that shows you really that once you reach around age 50, the exact replication of these pediatric regimens with these high doses and frequent doses of asparaginase, high doses of glucocorticoids, etc., is probably not tolerable. And this is due to increasing toxicity. So what are we going to do in our older adult population? And this is the population, I think, where we really are bold enough to make some significant advances because of the poor outcomes that we have previously experienced in our older adults with ALL. just to go back to that early slide that I showed you, these were the very poor outcomes of adults with ALL over the age of 60 on CALGB studies over the past number of decades. And so this is the group where all of us are trying to make bigger changes and be a little more bold in changing our regimens. One of the leaders in this change has been shown to you by the MD Anderson group, where they use the inotuzumab ozogamicin to replace the very high intensity chemotherapy regimen of hyper-CVAD that they have used for many decades at MD Anderson. And in this case, they took away the very intensive therapy, removed the anthracycline altogether, and added instead inotuzumab. The median age of this population was 68 years. You've seen these data published already. But what it shows you is that the CR rates in the frontline setting now with inotuzumab and very low dose chemotherapy are extremely high, and the median progression-free survival much better than what I showed you on the previous slide, suggesting that perhaps by adding these novel agents in the frontline with reduced dose intensity chemotherapy, we can achieve very respectable results. We're even getting more bold in the sense of moving away from much chemotherapy at all. This is a trial that was done and led by the Southwest Oncology Group by Dr. Anjali Advani. Update was presented this year at ASH, but it shows that one could use in older adults, and you can see here the starting age was 65 years and above, was really driven by use of blinatumomab only with dexamethasone and IT chemotherapy. So other than the steroid free regimen, just blinatumomab induction with dex and IT chemo, blinatumomab consolidation with IT chemo, and then some low dose chemotherapy comes in with POMP maintenance. In this case, the median age was 75 years, and many of the patients were relatively more frail. There were no deaths during the first 28 days. The treatment was well tolerated. There was minimal neurotoxicity, which was a concern with the blinatumomab in the front line, especially in an older adult population. And the CR rate was 66%. The median survival was still short at 1.3 years, but overall survival quite good at 1 year. And this gave us an encouraging basis to move forward. So currently in the US, in the National Cancer Trials Network, we are now doing a study that incorporates both agents that I mentioned, inotuzumab and blinatumomab, and it's really a chemotherapy-free regimen for adults over the age of 60 years. And we are accruing actively on this trial. So we've gone from the intensive approaches to a modulated approach using both antibody therapy and chemotherapy to now a totally chemotherapy-free regimen for our older adult population, and we will hopefully see good results. This trial, again, is more than 50% accrued, but we don't have much data. I can tell you from my own experience that it is a quite well-tolerated regimen with nice response rates so far. Dr. Gokbajet already showed you this beautiful paper that was just recently published showing the same approach in Ph-positive ALL, where we're now incorporating the blinatumomab into frontline therapy. This is the Italian study that was just published, and Dr. Gokbajet just showed you the lovely results of being able to use dasatinib, a targeted kinase inhibitor, with blinatumomab and IT chemotherapy in the frontline setting. Very similar approach to the non-Ph positive ALL that I just showed you from Dr. Advani's study. And again, this is a fully published manuscript now. You saw the schema in the previous talk, so I won't belabor it, but basically, again, just dasatinib, blinatumomab, no additional chemotherapy other than intrathecal therapy. And the endpoint of the study was MRD response after 2 cycles of blinatumomab. And you can see the results here. MRD response of 60, negative response of 60%, and the outstanding overall and disease-free survival, with a number of patients in this study still undergoing allogeneic transplant in first remission, but not all patients undergoing allogeneic transplant in first remission. So again, the concept of moving away from the regimens that have caused a lot of toxicity in our older adult population by incorporating these novel and very, very effective targeted antibody strategies. What about TALL? TALL remains a bit of a bigger challenge since we have not yet developed antibodies to T-cell antigens that have been able to be faithfully used in the actual clinical setting. There are a number of strategies going on now that may be able to enhance response in patients with TALL. One of the things that has been shown is that we know that patients with TALL in the standard treatment approaches do just as well now as patients with BALL, and in some cases even better. These are our results from the 10403 trial, showing you that TALL patients do well, but as I showed you on the previous slide at the very beginning, MRD positivity in this group is also very predictive of outcome, and therefore it would be nice to have agents that we could use to eradicate MRD in patients with TALL. As I mentioned, we don't yet have these antibodies in the frontline therapy. There are some strategies that are being developed now, but we don't have those. What we do have is nelarabine, which has been a drug that's been approved for relapsed TALL for a long period of time. And a number of years ago, the pediatric group in the United States, the Children's Oncology Group, did a study where they did a very similar thing to what we're doing now with the antibodies, where they added nelarabine as a module of treatment in several time points during frontline pediatric intensified therapy for patients with TALL. So in essentially taking a pediatric regimen and interspersing, excuse me, a number of cycles of nelarabine into the frontline setting. And when they did that, they found an outstanding 4-year disease-free survival of about 89% when nelarabine was added to the frontline treatment. These are patients ages 2 to 30 years. So a younger patient population, but including some young adults with ALL. So interestingly, the addition of nelarabine is important for even the higher risk subsets of TALL, including the early T precursor ALL patients, which previously, as I'm going to show you here on the right, have done very, very poorly. In this study, with the addition of nelarabine in this pediatric, largely pediatric group of patients, the addition of nelarabine resulted in equally good outcomes for these early T precursor ALL patients. So it is very encouraging that this might be at least a very good approach with a drug that we currently have in our armamentarium to move forward with patients, for patients with TALL. So in conclusion, the adoption of pediatric regimens in young adults with ALL has improved survival rates, but toxicity limits expansion into older adult populations. And new targeted antibodies in the frontline therapy for BALL are being tested to improve event-free and overall survival, with the goal of early eradication of minimal residual disease, with the hope of having minimal toxicity. And nelarabine in the TALL patients has been shown, at least in a pediatric population and young adult population, to improve event-free and overall survival. We can now move, as you've seen here on these slides, to minimize and potentially, we don't know that yet, eliminate much chemotherapy by incorporating these antibodies into frontline therapy of older adults, where we've really been able to be more bold because of the poor outcomes with our traditional approaches. And as you saw, from both my quick slide there and Dr. Gokbaje's presentation that patients with pH-positive ALL and trials in that setting have really already led the way in this department. Is the future of ALL therapeutics chemotherapy free? Well, we don't know. The wisdom of the older adult studies or older adults will inform our approach to the younger patients. And there are other exciting targets for patients, especially with TALL, where we don't have such important and useful antibodies yet, by targeting potentially survival pathways, and the BCL pathway targeting is bearing fruit. I didn't have time to talk about it today in the main talk, but perhaps we could discuss during the discussion. And that has shown proof of principle in the relapse setting and now being incorporated potentially into frontline trials that we're planning here in the United States. And with that, I'd like to say thank you. Again, thank you so much to the organizers for inviting me. And thank you for your patience with my technical inabilities. And I'd like to thank my colleagues at the University of Chicago and around the country in the cooperative group setting who are listed here on this slide. Thank you so much.
Thank you, Prof. Stock, for an elegant talk as usual. And I have to say your technical skills actually is much better than many of us.
Thank you. That is very generous of you.
So I will open the floor. I mean, we will have a Q&A about ALL, and I would ask also Dr. Gokbaje to be with us and unmute her mic. And so I would like to remind the attendees, kindly write your question in the Ask Question tab. So the first question I have, I can maybe address it to Dr. Nicola. How do you deal with, how do you test for MRD using the flow cytometry in a patient who is post-blinatumomab, specifically for CD19 as a basic gating?
Okay, that's a very good question, but I'm probably not the right person to answer it, because there are some insecurities about the flow cytometric MRD testing, and this is the reason why in Germany we solely use the PCR method. And but I think the leukemia-specific panels after immunotherapy with blinatumomab should, of course, consider that CD19 is not the marker which should be included in the leukemia-specific subtype. There, because of the loss, which occurs less frequently than in the CAR T-cell setting, but still some of the patients treated with blinatumomab, around 20%, lose the CD19 on the surface at a further relapse. So for this and other reasons, we still prefer the PCR for MRD testing.
Okay, thank you. Another question, I will address it to Dr. Stock. Are you using any targeted therapies post allogeneic bone marrow transplant as a maintenance, like blinatumomab maintenance or inotuzumab maintenance?
Yeah, that's a really interesting question. At our center, we are not using that approach, but there have been some, there have been a couple of sort of posters anyway that I've seen on the use of blinatumomab anyway, post-transplant, to try to eradicate MRD in those patients who are still MRD positive. So, and that was a poster that was presented last year at ASH from the MD Anderson group. It didn't look so promising, but again, these patients were still MRD positive post-transplant, and it was difficult in those patients to eradicate MRD, perhaps because by the time blinatumomab was instituted, it was already, the disease burden was already getting too high. But it is an interesting idea. It's just that, of course, post-transplant, the use of inotuzumab might be quite worrisome with the risk of veno-occlusive disease, and the use of blinatumomab, while feasible, is not the easiest drug to administer simply because of its infusion in patients who've just finished a prolonged therapeutic course. But I don't know of any frontline trials in a randomized fashion that is looking at that in patients with ALL, MRD positive or MRD negative. Perhaps, Nicola, I don't know if there's anything going on in Europe in that setting.
So in the trial which I've shown you with blinatumomab and the MRD testing, we plan to include patients post-transplant.
I see.
But unfortunately, it doesn't work. So unfortunately, the transplanters do not consider this option. First of all, they reduce the immunosuppression, and then they think about DLI. I think it would be worth a try to use blinatumomab, and but not very early after transplant, maybe because you need active T cells for the activity of this compound, and very early after the transplant, this may be a problem. So
yeah,
there's also a trial ongoing with combination of DLI and blinatumomab. It could also be interesting.
Yeah,
but it recruits very slowly. As you said, the problems are there are a lot of problems in the transplanted patients.
Yeah, it's hard, and that study from MD Anderson, again, I think it was a combination of either waiting too long because you wanted the T cells present, or the fact that there were no T cells because the immunosuppression was still present. Exactly, it's confounding. But it is a reasonable question. Are you testing that at all in Saudi Arabia?
No, actually, we are not. Although, I mean, some colleagues actually raised this based on the posters that you mentioned. Okay, so the other question I have, this is to Dr. Go-Budget, is regarding the upper age limit for CAR T-cell and ALL. Are we expecting an increase on the upper age limit? I mean, currently it's at 25.
Yeah, I think that is really a big problem that the CAR T cells end at this age. So it is totally unacceptable. But we have to accept this because the trial was designed in this way. I would certainly think that we need the CAR T cells also in older patients, and there are some ongoing trials from KITE, for example, which may help that we get another product for the patient population older than 35. But I don't see a lot of data for the adult population, so real older patients. So I think we would have to wait for tolerability data, for example. But I am quite confident that the upper age limit would be increased. Currently in Germany, we cannot use a CAR T cell if the patient is 26 years old. Done.
Same with us. But we heard that the KITE product is supposed to be approved very soon. That's what we've been hearing, but we don't know that.
In the same line with the CAR T cell, are you using it as a first line for the salvage or relapse, or after second line of treatment?
Well, in the United States, I mean, I think probably everywhere, the trials are mostly for second line or not even second line treatment. It's certainly not in the front line. Although I have to say that our pediatric group, the Children's Oncology group, does have in their frontline trial now. At the end, if there's still MRD positivity, patients then get CAR T cell, can have a CAR T cell implemented. But that's, again, the pediatric population where the CAR T cell has already been approved for the relapse. But in our trials, it's mostly second relapse where the CAR T cell product is being tested, not even in first relapse.
Yeah. Same for Germany. So it is also the marketing authorization is not for first relapse, and because of the high price, our insurance companies do not accept any deviation.
Okay. Another question is regarding Down syndromes with ALL. How would you consolidate treatment? Transplant, chemo, targeted therapy, CAR T cell? We'll start with Wendy.
Well, I actually have very limited experience myself in the adult population, but the pediatricians now have published a number of studies recently showing equally good outcomes for the patients with Down syndrome, ALL, using these pediatric approaches. Of course, they're modified to avoid the high-dose methotrexate and are using more of the Capezi, the intermediate dose methotrexate with the asparaginase. But they've gotten very, very excellent outcomes for those patients. And while we don't have any exclusions on our adult trials for enrollment of Down syndrome patients, we have very, very few of them. So I really don't know how to comment on the use of this in the older adult or the young adult Down syndrome population. How about you, Nicola?
So yeah, we collect this information in our registry. We have yeah, few patients as well, maybe 10 or 15 all over Germany. And as the pediatricians, we recommend to use a standard regimen, maybe reducing the daunorubicin in the induction also, and of course check the potential cardiac complications in these patients and reduce the methotrexate. And if the patients remain MRD positive, they will receive also blinatumomab and try to get to transplant them. Yeah. So we try the same as in non-Down syndrome patients with some modifications.
Thank you. So I have another question regarding the T-cell ALL in CR1. How would you stratify the consolidation? Is it based on MRD?
Yes. We approach them in the exact same way as we do the as the B-ALL patients. However, unfortunately, we don't have a blinatumomab or an inotuzumab at this moment, but it looks very promising, the addition of nelarabine and in the frontline setting, which we've adopted at our own center for the patients with TALL who seem to tolerate the schedule quite well. But there are some interesting data on the addition of some of the BCL targeting agents, particularly venetoclax, in the frontline, in the relapse setting, excuse me, that we're going to think about bringing forward to these patients. But in terms of stratification, we do exactly the same. How about you?
Me?
So
yeah, or you, either.
Yeah.
So we have integrated nelarabine in the first-line treatment as consolidation also, and also in patients who remain MRD positive. So this is our blinatumomab in TALL, although it works less good, as I must admit. In addition, we have a rather poor outcome in patients with immature early TALL, and therefore these patients are, in our protocols, candidates for stem cell transplantation.
Yeah, I think that population is such a tough one in terms of what to know what to do, because the pediatric data show that if MRD is eradicated, which it seems to be in these ETP patients, they do just as well, as I showed on that one slide. But my own personal experience has not been quite so favorable, even with MRD negativity. And perhaps that's the sensitivity of the MRD testing that we use, and we now use a more sensitive test. But I agree that this is a high-risk subset and can be transplant candidates.
Okay, thank you so much, Professor Cook-Budget and Professor Stuck, for very informative talks and deliberation on the questions and answers. I think we will move now to the last talk of the first session. So it will be on the burden of AML, mutation and prognostication implications. This is still a satellite talk and will be given by Dr. Neville Dever. Dr. Dever is Associate Professor of Hematology at MD Anderson Cancer Center. He has more than 200 publications. He's a director of Leukemia Research Alliance program. It's a privilege to have you, Dr. there with us. If you kindly unmute. Okay, I see your presentation.
Hello?
Yes,
Hi.
I hear you.
I'm trying to put on the webcam. Let me see.
You are now ready to go. Please go.
Okay. Well, can you see the video, or that's okay? I just go ahead.
I can't see it, but I think that's fine.
I think that's fine.
Yes, we can see it. I can see it.
Okay.
You can. I can see it. Please go ahead. Dr. Naval, you are on mute still. We can't hear you back. Can you please unmute yourself? Dr. Naval, you are on mute still. We can't hear you back.
I can see you, Dr. Naval, now, but I can't hear you.
Okay. You are on mute. I can see that you are muted already.
Dr. Naval, do you hear me?
You are off mute. Please try to talk. We heard you before. You are ready to go, Dr. Nabil.
Okay, can you all hear me now?
Yes, thank you.
All right, great. Thank you. Sorry, I don't know what happened. I reloaded the page and it is working. So yeah, it's a pleasure to speak to you all here. I'm going to be speaking about the mutations and prognostic implications in acute myeloid leukemia. I work at the MD Anderson Cancer Center in Houston, Texas, and I focus on AML clinical trial development. This is a Astellas satellite symposium. The opinions here are my own opinions and experiences. These are my disclosures from research funding as well as advisory and consultancy. And there may be some comments on any medications that may not be approved. So when we think about acute myeloid leukemia, I think it's important to look at the average age of diagnosis of patients. So the average age of the AML patient is 69 years. And as you can see, the majority of patients are older patients. Well, about 70% of patients are above 50 years of age. And that is important because we also see that the survival of patients comes down as they become older. And this is because of a variety of factors. Older patients, they tend to have more adverse cytogenetics. Frequently, they are more frail. They cannot tolerate intensive chemotherapy. There may be other issues related to drug sensitivity in this population. So this has been a major challenge for acute myeloid leukemia therapy development, is how can we improve outcomes in the most common group of patients, which is the patients above 60 and 65 years. So one of the major steps forward in the treatment of AML has been the emergence of extensive molecular annotations and sequencing. And here you can see that we now know the most common mutations that are seen across AML, and these include NPM1, FLT3, IDH1/2, and then other ones that may not be as common but are very important, like TP53. And on the right-hand side, you can see how prognostically important these mutations are. So historically, 15, 20 years ago, we used to say patients are intermediate cytogenetics, but that included almost 2/3 of the patients. Now we see that when we incorporate the molecular information into that intermediate cytogenetic population, you can actually prognostically stratify it into much more detail. And there can be some patients who will be intermediate or diploid cytogenetics who could have very favorable outcomes, like the NPM1 mutated FLT3 wild type. And then there can be some who would also be intermediate diploid cytogenetics, but can have. Can you hear me?
Yes.
Okay.
Yes, I can hear you.
Okay, thanks. Yeah, who could have very adverse outcomes, such as patients with TP53 mutations, who even if they're diploid, can do very, very poorly. So I think it's very important to use molecular information in frontline, both in prognostication, also for treatment selection, because we have targeted therapies as well as antibodies that work in particular subsets, and potentially for transplant decision making as well. So this has led to the recent version of the ELN, the ELN 2017. There will be a more updated version coming out soon as well. And in the ELN 2017, you do see that we now have incorporation of the most important and common molecular mutations. This includes FLT3, NPM1, CEBPA, as well as mutations that independently will predict a adverse outcome in spite of having normal or diploid cytogenetics. These include TP53, RUNX1, ASXL1. The other thing that we're starting to realize is that individual mutations may not be sufficient to give the full prognostic picture. For example, if a patient emails me or physician emails me and says, I have a FLT3 mutation, what is my prognosis and therapy? I cannot give an answer because, as you see, FLT3 can be unfavorable, intermediate, adverse. What I really need to know are two things. What is the FLT3 allelic ratio or allelic burden, and what is the co-occurrence of NPM1? And so just knowing one mutation is not sufficient, and you will see, I think, over the next 5 to 10 years, new iterations of the ELN NCCN that will start incorporating mutational combinations and the impact of one mutation on the other, as well as the actual burden of mutation, not just qualitatively is it positive, negative, but actually how much mutation is present. All of this, as I mentioned, has significant prognostic value. And as you can see here, AML is not one group. So when you see a patient with AML and they say, doctor, what is my prognosis? there is not one answer. Obviously, you can see from this slide, it could be 95% in patients who have APL, 80 to 85% in core binding, and then you can go all the way to the complex karyotype with TP53 who have less than 5% survival at 4 to 5 years. So the prognostic in mutation and cytogenetics is very critical upfront for understanding the outcomes, but also for developing therapy, because a particular therapy that may have a marginal benefit in a favorable group could be very, very effective in certain high-risk groups. And these include new emerging therapies, including TP53 targeting drugs, CD47 antibodies, and others, and MLL rearrangement targeting drugs like menin inhibitors. So it is very important to know the baseline prognosis, both for the patient and for treatment. I'm sorry about the formatting. I think we put this from my template to the other template, and that's causing some issues. But hopefully you can see molecular studies also have therapeutic implication beyond prognosis. And this includes at least 4 major groups for which we have either approved drugs or emerging drugs. FLT3, the first one, the most important, the most common, and for the last 12 years, many different FLT3 inhibitors have gone through trials and are now getting approved across the world. IDH1 and 2, more recent story in the US, we do have IDH inhibitors now approved in relapse, as well as some data emerging in frontline. And then recently now there are NPM1 and MLL rearrangement targeting drugs. Very exciting, a group of drugs called menin inhibitors. There are 2 in clinic and 2-3 more coming very, very quickly. And from the initial data, we are very, very excited and think this could be another major breakthrough in targeted therapy after FLT3 IDH. And then for TP53, we are still looking, but there are now a couple of approaches using immune therapy, CD47 antibodies, and potentially APR that may work here. So we really are moving into a very targeted, selective approach for AML, not just one broad treatment. So unfortunately, this slide looks like it was a lot of the information was lost in formatting. But the bottom line is that in AML treatment, we have seen accelerated progress. And actually, in the last 3 years in the United States, we have had 9 new drug approvals. This is quite fantastic, because for the previous 30 years put together, we really did not have any major drug approved. So this is now, of course, happening in the rest of the world. Those drugs are being approved. And now the challenge is how we use them optimally, how we mitigate toxicities, and really, to me personally and at MD Anderson, how we combine them optimally, either sequentially or in an MRD setting to really improve the outcome, something that you have heard a lot from the ALL colleagues in the previous talks. And I think we now have tools like this for AML that we have to optimize. So talking about FLT3, FLT3 mutation, as I mentioned, is the most common. About 30% of patients will have a FLT3, either ITD or TKD mutation. The ITD is the most common among the two. And as you can see in this paper that was published almost 20 years ago now, the first one to show the impact of FLT3 on outcome, you can see that people who have a FLT3 mutation have a very adverse outcome. 5-year survival in ITD mutated was about 25%. Now, since this is, the drug is not yet approved, I won't be talking about therapeutic outcomes, but there's a lot of published data out there from many colleagues across the country, as well as from us at MD Anderson, showing how this has changed dramatically by using upfront therapy, integrating FLT3 inhibitors, where we're now reporting in publications and presentations 4- and 5-year survivals of 65 to 75%, starting at 25%. So no doubt in our mind, the identification of FLT3 and the incorporation of FLT3 inhibitors has changed the face of this disease dramatically, and will continue as we move from first-generation FLT3 inhibitors that are currently available to second and third generation that are going through frontline trials in combination with chemo. The other thing with FLT3 inhibitors and FLT3 mutations is that, again, it is not yes and no. You can have a FLT3 mutation positive patient who may have a very low allelic burden, and the prognostic impact of that mutation may be limited to none. And you can have others who have very high allelic burden, where the FLT3 is the primary driver of the outcome. And so every quartile increase in FLT3 that was nicely shown in this paper by the Spanish group impacted the response as well as the survival and event-free survival. Here, looking at the impact of co-mutations, what is seen is, unfortunately, again, the formatting has been affected in the transfer, But basically, we do know that co-mutations can impact the outcome of FLT3. And what we see is that people who have a TET2 mutation, people who have a DNMT3A mutation or trisomy 8, they are in the black curve. So even if they have a FLT3, but the co-mutations make it much worse. On the other hand, those who are FLT3 with a NPM1 and a low allelic burden FLT3 and none of the co-occurring adverse mutations I mentioned can actually do quite well. This is looking at the impact of the ITD burden and cytogenetics. So cytogenetics still has a prognostic value. People who have poor risk cytogenetics with the FLT3 can do quite poorly, whereas those who have FLT3 and have favorable good risk cytogenetics here in the purple curve can do quite well. So now looking at the therapeutic approach in general, not focusing on any specific drugs. Historically, the goals of therapy for younger, fitter AML, and they continue today, not just historically, have been to try to cure patients, right? And that's the unique thing about acute myeloid leukemia compared to many, many solid tumors. It's a kind of binary. Either you achieve a remission and you achieve long-term 5-year survival, or you end up with high toxicity and potentially early mortality and toxicities. And so the goal with younger patients is still intensive induction, anthracycline cytarabine based. There are many variations of this that I will not go into, but in our experience at Anderson, using pure analog based approach such as FLAG-IDA regimens have shown good efficacy. And then once in remission, we decide transplant or no transplant based on their baseline molecular cytogenetics. I will say the majority of our patients, we still lean towards transplant at this time, which remains a curative option. And we are seeing about 50 to 60%, in fact, in our most recent analysis, about 65% 5-year survival. I think Dr. Kantarjan is speaking in a couple of hours, and he will show you some of our update analysis. So we are making progress in younger AML. Older AML, not as clear yet. I think we are making progress, but we are still far away from where we would like to be. The 5-year survivals till 2015 were about 10% or less. Now with the advent of new drugs, FLT3 inhibitors, BCL2 inhibitors, IDH, we're getting to 30, 35%, but still need to improve this quite significantly. So the traditional approach to AML therapy has been two things, because that's all we had. Either you get intensive induction chemotherapy, such as 7+3 anthracycline cytarabine or FLAG-IDA or CLIA-based, and then we go to transplant for majority of patients after they achieve remission. For the unfit, the options were hypomethylating agent, decitabine, azacitidine sort of therapy, or supportive care, or clinical trial. So this was very limited selection that we had available. Now, this has changed quite dramatically. This was a recent paper that we published in Blood Cancer Journal with colleagues across the US and Europe. And you can see that there is a major shift, at least in US and in some regions, Australia, Europe, where drugs have become available, to using molecular information and cytogenetics to select therapy. And for patients who are young and fit for intensive therapy, we absolutely are looking right in the beginning to see if they have core binding factor AML, in which case we would add CD33 antibodies like gemtuzumab to the induction therapy. FLT3, we would add a FLT3 inhibitor. For patients who have therapy-related AML or AML with MDS-related cytogenetic changes, secondary AML, we would add CPX351-like drugs. And for the others, we would use intensive therapy. And there are now investigations looking at adding venetoclax to intensive therapy, which is showing very, very exciting early activity in frontline and relapse. Similar thing for the older AML, but now HMA-VEN is kind of the backbone, but can we improve that further by adding targeted therapies? And these are in trials. And for TP53, for the first time, we hope that we have a couple of approaches through immune targeting, CD47, macrophage activation, and potentially through other drugs like APR. But to get to this, what I showed you, to select these therapies, you really need that information. And this is now the big battle in many areas, how to quickly, because we know time is of essence, we cannot wait 21 days or 28 days like solid tumor to get molecular profiling information. So how can we get that data? And this is kind of the schema that many places are using. This is what we do at Anderson. We get quickly the bone marrow flow cytometry. We get the cytogenetics FISH, especially core binding factor and MDS-related cytogenetic changes FISH very quickly, usually 48 hours. So this helps us know if this patient has APL, core binding factor, or potential candidate for CPX351. And then we rush what we call a rapid molecular panel, 8 or 9 genes, FLT3, IDH, TP53, NPM1, CBPA, and then we proceed with therapy around day 5 or 7. And then we get a bigger panels coming in later, but that is for research, including other mutations, ASXL1, GATA2, RUNX1, etc. So the question is, how can one wait? This was a very nice analysis that was done by the German cooperative group, Dr. Rohlig and others, to say if you have a patient and if you waited 5 days or up to 10 days or up to 15 days, would that impact your outcome? Meaning, can you wait or should you just start therapy and then figure out what to do with mutation and cytogenetic information later? And what they showed was quite interesting, that even waiting between less than 5 days, 5 to 10 days, and up to even 10 to 15 days, although I think that is a little bit debatable, was not associated with adverse outcomes. They looked at 3 main features: early mortality, which is 60-day mortality, CR rates, and survival. Now, one has to be careful with this data a little bit because this was done in the setting of a cooperative group clinical trial. So these were all patients who could make it onto the trial. And we know we have a lot of patients who come in very sick, crashing and burning. And so, of course, you have to make individualized decision. But for the majority, 85, 90% of patients, where you can watch them closely, inpatient or outpatient, you can see that they're not highly proliferative, it is better to get molecular cytogenetic information and get the right selection up front rather than rushing to therapy. What about for patients who are fit for intensive therapy? We discussed this already a little bit. The selection is usually based on cytogenetics, whether they're core binding factor inversion 16821, or have therapy-related AML or AML with MDS-related cytogenetics, or a FLT3 mutation. And for others, we do the traditional induction with the addition in our center at this time on a trial of the venetoclax in the frontline setting. So this is our treatment algorithm that we published in a recent review of frontline patients who are FLT3 mutated, where we're doing the intensive chemo backbone with FLT3 inhibitor for induction, and then continuing that for consolidation. We prefer the second generation FLT3 inhibitors with induction in this scenario, although those are not yet approved in the frontline setting in the US, but this is done in the trial setting. And then the next question is, can we get the patient to transplant or not? In general, our approach and the data that we have published and others have published suggests that FLT3 in general should be considered for transplant. There is a debate in the low FLT3 NPM1 mutated, but we actually just did a recent analysis that will be at the EHA, showing that even in patients with very low FLT3 ITD, less than 0.1, who have a co-occurring NPM1, in fact, transplant still had a benefit. Those patients actually do quite well on their own, 60, 70%, but with transplant, we were able to get more than 90% alive at 3 years plus. So in our opinion, I think transplant still remains the goal for these patients who have a FLT3 mutation. And then, of course, post-transplant maintenance, as you may have heard, there are many trials showing benefit, and we do use a FLT3 inhibitor post-transplant for maintenance. We can skip this. We've already discussed this information. What about the role of transplant? And I think this was one of the seminal papers by Dr. Schlenk in the German group, showing that in FLT3 mutated patients, if you look at the right-hand curve, that the addition of transplant, that's the donor curve, did improve outcomes, but you can see the improvement was not complete, went from 20% to 35, 40%. Now with the incorporation of FLT3 inhibitors, transplant, post-transplant maintenance, we and others have started reporting up to 75% 3 and 5 year survival. So I think it's not one intervention, it's multiple interventions that are required. This was a paper we published, a review on ongoing FLT3 inhibitors trials, approvals, next steps, combinations. And it's important to note that all FLT3 inhibitors also are not one. There are different approaches. Some target type 1, some target type 2. This is important because the type 1 inhibitors can target both the ITD and the TKD. So they have an advantage where they can cover both types of mutations. The type 2 inhibitors are very, very potent, for example, quizartinib, but we can see escape through the acquisition of on-target TKD mutations. So one has to be aware of that. But I personally think both of these will have roles, and we actually have data using them in different salvage settings. And we often find that one may overcome the resistance that is seen with the other. What about the unfit AML, patients who are not suitable for intensive chemotherapy? This is a scoring system that Dr. Kantarjan from our group published many years ago that continues to be used. There are variations of this that have been used by Fred Hutch and published and other groups. And what you see is that when you use these factors, and there's an online scoring system, one can easily go on Google and just say online intensive chemotherapy mortality score. You will see this, and it will give you a predicted induction mortality. Many of us do this when we see the patient. Okay, he looks frail. Okay, he looks good. And many times I think if you have good experience in a major center, you're probably correct. But if one wanted to be objective, this will tell you the predicted induction mortality based on analysis of 1,200 patients at MD Anderson. This is again, discussing the fact of the improvement we're seeing in the younger patients over the last decade. In fact, the most recent curves are now looking at close to about 65% at 3 to 4 years. And in the older patients, unfortunately, not much progress. But again, in the most recent era, 2015 to 20, we are starting to see a improvement at about 30, 35%, 3 to 4 year survival. This is predominantly with the BCL2 inhibitor being added, and we hope, and this is what I'm showing here, that we're starting to see now maybe an improvement, although the follow-up is short. So we have to wait and see in time. FLT3, the other important thing to note is that the frequency of this mutation is much less common in older. So as you can see, pediatric groups, it's uncommon. Then it peaks in the 20 to 40, 50 population, and then it drops. So we do a lot of trials in older FLT3 mutated, but it is challenging to find these patients. And we still are not sure what is the best approach. Aza-Ven is approved in the US for this population, but as you may know, the survival is only around 11 to 12 months in the FLT3 mutated. So can you add a FLT3 inhibitor, do a triplet? Can you do a sequential approach? What is the best way? We are looking at that at this time and trying to find the optimal path. This is our current approach. Again, at MD Anderson, we do have frontline combinations of azacitidine HMA with BCL2 inhibitor with second generation FLT3 inhibitors that are ongoing in the triplet setting. And we've shown some of the data at the ASH meeting last year, and we'll be updating at EHA. And I would say very, very promising remission and molecular and MRD clearance, but we do see myelosuppression. Luckily, the early mortality is still 0, but one has to be very familiar. But I do think this is the way we will be going in the future, similar to myeloma, where we combine drugs in the frontline setting with optimization for myelosuppression and toxicities. And I think it's very important, even in relapse setting, to realize that the escape clones are usually driven by one or more major mutations. And in relapse refractory setting, it is very important to try and identify a targetable mutation. That is really the only true chance your patient will have of getting into a remission. We looked at this in the FLT3 inhibitor field, and actually very interesting data that was presented by Dr. Alotaibi from Saudi, who was a fellow here, who has now gone back there and is working with your group. He did an excellent analysis that was published in the Blood Cancer Discovery, looking at the secondary resistance patterns in patients who received different FLT3 inhibitor-based therapies and trying to understand what happens after you get a FLT3 inhibitor and drives the resistance. And what we found, and again, I apologize because somehow the formatting was messed up in this transfer, but we looked at a big number, almost 1,000 patients, and we found 70 patients who responded to a FLT3 inhibitor and relapse, and then had a molecular full sequencing at baseline and relapse. That was hard to find, but we found about 70 such patients. And then we had a cohort of 100 patients who were primary resistance, meaning that they just didn't respond, but we had the NGS profiling done at the baseline. So the key findings are quite interesting, that FLT3 mutation is actually lost in about 1/4 of the patients. So you have a patient, FLT3 mutation, you give them FLT3 inhibitor, they relapse 6 months, a year later, and you will see that 25 to 30% will no longer have a detectable FLT3. This has been published by others as well. So it's important to check FLT3 at the time of relapse, because you may not have a FLT3 mutation, then you don't want to give a FLT3 inhibitor. And the opposite is true too. We have published many years ago that about 20% of people who did not have a FLT3 at baseline could acquire a FLT3 at relapse. So the point is, you need to check FLT3 again at relapse before deciding a therapy. There may be people who acquired a FLT3 who didn't have it before. There may be people who had a FLT3 before who have lost it. The other thing we saw is that when you use type 1 FLT3 inhibitors, you don't see D835 mutations. 0 patients had D835 escape. On the other hand, with the type 2, you can see these as escape mutations in about 30%. So there may be a benefit of type 1 FLT3 inhibitors. There are other pathways that cause resistance, though, in the type 1 inhibitors. So it's not that they don't get resistance, it's just different. It's off-target parallel pro-survival pathways, such as the MAP kinase RAS, that causes resistance. So one has to look at those, and we have started working on developing MAP kinase RAS inhibitors to overcome that mutational escape. The other thing we saw is that patients who had a loss of the FLT3 and relapse actually do better. So, it is probably the fact that the FLT3 inhibitor was able to get rid of the FLT3 clone. So even though that patient relapsed, they relapsed with a less proliferative, less aggressive clone and could have a better outcome, as you can see. So again, important to check the FLT3 at relapse, may have both therapeutic and prognostic impact. And the other thing we saw is that any emergent mutations that were driving resistance, such as the FLT3 TKD or the RAS MAP kinase, could drive a worse outcome. Again, not too much we can do for some of these, like the RAS MAP kinase today. Of course, for the D835, you can use type 1 FLT3 inhibitors. So in conclusion, what we saw in this analysis, which is now published and available, is that it is very important to check FLT3 at relapse. Some people lose it, about 30%, others may gain it. Type 1 inhibitors may have an advantage that they cover the ITD and TKD, especially when they're combined up front with chemo or HMA with ongoing trials. This may be very, very beneficial, but they do have their own mechanisms of resistance and escape, usually through the emergent mutations in the RAS MAP kinase pathways. And again, we think that this was all with single agent or low dose chemo combo, and hopefully with venetoclax combinations with FLT3 or intensive chemo with FLT3, we will be able to overcome this. This was a paper we had published a few years ago in Blood, again showing that FLT3 is a very, very complicated pathway. It's not a straightforward just using FLT3 inhibitor. This really shows why we need combinations. There are multiple parallel pro-survival aspects that are involved, activation of mTOR, RAS, STAT5, bone marrow microenvironment, CXCR4. And so I think we need to keep developing novel combos in multiple FLT3 inhibitors, just like we have multiple TKIs in CML. And with that, I will stop. Thank you very much. Please feel free to contact me anytime for any acute leukemia-related questions. Thank you.
Thank you, Professor Dever, for an excellent talk. Due to the time, I think we will ask the attendees. So we have now more than 3,100. If you have any question, just email Dr. Dever, and I will kindly ask him to answer as much as he can.
Absolutely. Thank you.
Yeah, so we will conclude the first session of today of the annual Saudi Hematology Congress. So we will have we will have a 10 minutes break, and I would like to remind the attendees that the exhibition will open now, and there will be an interactive live chat with the sponsors. If anyone have any question, that he can interact with the sponsoring companies, and we shall be back at 5:05, which is Saudi time. So exactly 7 minutes from now. Thank you all. See you in a bit. طيب team, can we go live?
We're ready to go.
Right, thank you. Welcome all again. I would like to welcome all the 3,000 attendees who are still with us in the second day of the annual Saudi Hematology Congress. So we will start the next session, and we have Dr. Rami Kumrokji, who is a hematologist and clinical investigator from the Moffitt Cancer Center. He has a special interest and several ongoing trials in myeloid malignancy, MDS, acute myeloid leukemia. Dr. Rami, he will talk about new therapeutics and new targets in myelodysplastic syndrome. Dr. Rami, the floor is yours.
Assalamu alaikum. Thank you for the kind introduction and for the kind invitation. So in the coming 25 minutes, hopefully I'll be able to cover some of the new advances and promises in myelodysplastic syndrome. Finally, we are following the heels of AML with new drugs and exciting clinical trials. Those are my conflicts of interest. And as you know, myelodysplastic syndrome is a heterogeneous group of neoplastic stem cell diseases, presents with bone marrow failure, cytopenias, and the related complications, tendency to progress to AML. Not every patient progresses to AML, around 30 to 40% will, but unfortunately around 50 to 60% of the patients will die from complications of the disease, namely related to cytopenias and its interaction with other comorbidities. Nowadays, we can demonstrate evidence of clonality either by cytogenetics or somatic gene mutations in almost 90% of the patients. And as it's well known, dysplasia still is the hallmark cytologic morphology of the disease. Upon establishing the diagnosis, we usually risk stratify the patients. And the most used staging system at this point is the revised IPSS, where we divide those patients into 5 categories based on the blast percentage, cytopenias, and the cytogenetic abnormalities. And we try at the end to divide the patients into 2 main categories: lower risk group, where our goal is going to be alleviating cytopenias, treating anemia, thrombocytopenia, etc., or a higher risk patients, where our goal will be trying to improve the survival and alter the natural history of the disease. We currently complement the results of the revised IPSS or the risk stratification by looking at the somatic gene mutations. This is work by Rafael Behar many years ago, looking at 5 gene mutations that any of them upstaged patients' risk group. And we complement that with the revised IPSS. I think it's what to remember importantly, obviously, TP53 is one of the worst mutations in myeloid diseases. And the only favorable mutation in myelodysplastic syndrome is really SF3B1, which is a splicing mutation. So this is currently our treatment algorithm for patients with anemia for lower risk disease. In most of the lower risk cases, we are treating for anemia. Rarely 10% will need treatment for isolated thrombocytopenia, and neutropenia typically is not symptomatic, so I usually don't treat neutropenia alone. The presence of other cytopenias like thrombocytopenia or neutropenia could dictate your choice of therapy for anemia, but not often the indication. Most of MDS patients obviously present with anemia and eventually, become transfusion dependent. So erythroid stimulating agents for anemia are still reasonable option, particularly in patients with low endogenous serum EPO. For patients with deletion 5q, lenalidomide is the standard treatment for those patients. Nowadays, for patients with MDS with ring sideroblast, luspatercept, which we will talk about in details, is approved option. For other patients that are non-del 5q, that don't have ring sideroblast, if they are young, some institutions, if they have hyposteroid bone marrow, we favor immunosuppressive therapy. This is a short course of treatment with durable trilineage responses. Finally, for the rest of the patients, if they are not young and don't have deletion 5q and don't have ring sideroblast, options could be still lenalidomide for the non-del 5q, plus minus erythropoietin. We just published our study from the US Center Group looking at the combination len-EPO in that category, showing higher responses. or hypomethylating agents. And sometimes we pick hypomethylating agents in presence of concomitant thrombocytopenia or neutropenia. So we reserve the use of lenalidomide in the NANDAL5Q for patients with pure anemia. So luspatercept is the first drug approved in a decade now, or more than a decade now, for MDS. And it's a neutralizing antibody that binds and neutralizes TGF-beta ligands in the serum before binding the receptor. And it turns out that TGF-beta ligands or TGF-beta pathway is important in MDS, being overactivated, contributing to the myelosuppression. And many of the TGF-beta ligands actually work as negative regulators of the terminal erythroid differentiation, blocking the last step in erythroid differentiation. So what luspatercept does, it binds those ligands in the serum, neutralizing them, and leading to release of the terminal erythroid differentiation block. So we use the term erythroid maturating agent. We originally did studies with sotatercept, which is a similar compound that demonstrated the first activity in MDS. Then our colleagues in Germany did the initial studies with luspatercept. With both luspatercept and sotatercept, we observed higher responses in patients with ring sideroblasts, and that led to the medalist study. I'm not able to advance the slides. So the medalist study that led to the approval of the drug.
Okay, can we move this next slide, please? Technical team.
So the medalist study randomized patients with lower risk MDS, no blast, ring sideroblast, transfusion dependent, to either luspatercept or placebo, and the primary endpoint was transfusion independence.
Sorry, Dr. Rami, we're waiting for the technical team.
I think perfect. Thank you. So this is the design of the medalist study, as I mentioned, between luspatercept, which is an injection every 3 weeks, and placebo. The baseline characteristics are shown here. Almost half of the patients were heavily transfusion dependent. Obviously, as expected, 90% of the patients will harbor the SF3B1 mutation, and most of those patients had prior ESA use. The small minority that did not have erythroid-stimulating agents had high endogenous serum EPO, predicting low chance of response. And this is the bottom line: the transfusion independency at 8 weeks, and at the 16 weeks. Obviously, luspatercept had around 30% transfusion independency in the study compared to the placebo, meeting the primary endpoint. And when you look at the details and the erythroid responses, it really turns out that those patients that are not heavily transfusion dependent, so introducing the treatment early on, have the highest yield or benefit from the treatment. So the mean hemoglobin increase in those patients that were less than 4 units blood transfusion dependent approached almost 70% with using luspatercept. The major side effects were fatigue, some edema, some GI toxicity, namely or mostly during the first 2 cycles of treatment, and that subsequently subsides. We usually start with a 1 milligram per kg dosing. After 2 doses, escalate to 1.33, and after 2 doses to 1.75. And if no response is seen, then we stop the treatment. If patients are responding, obviously we continue. In our experience, if patients are heavily transfusion dependent, they need higher dosing of the luspatercept, and it's being explored in patients with upfront MDS compared to erythroid-stimulating agents in the COMMAND study. The other drug to discuss in lower risk is emtelostat. This is a telomerase inhibitor that targets telomerase. Telomere length is shortened in MDS. And the idea here is almost like the synthetic lethality, further shortening the telomere in the malignant cells, leading to their apoptosis. This had been also tested in patients with myeloproliferative diseases. So this phase 2 now is published in JCO, by Dr. Platzbecker and Stinsma that looked at once-a-month IV emtilistat in lower-risk MDS patients that were heavily transfusion-dependent. Majority of them had ring sideroblasts, similar to the luspatercept study, and showed promising results with almost 40% of the patients becoming transfusion independent. And what's more important, around 1/3 of the patients maintaining this response for around a year. In terms of side effects, we do observe cytopenia on target with neutropenia and thrombocytopenia, usually reversible by the time of the second round, but that's the main toxicity with the treatment. And we see on-target activity with inhibition of the telomerase activity and the TERT expression that does correlate with the transfusion independency and duration of response. And very interestingly, in a very small cohort of patients with the SF3B1, 11 patients, we see a reduction in the allele burden of the SF3B1, suggesting that this drug could have disease-modifying activity. So now emtilistat is in a phase 3 in lower-risk MDS patients after ESA failure. I think what's distinguishing it a little bit from luspatercept is that the signal of response was observed even in patients with higher transfusion burden. However, it does have the myelosuppression more than what we observe with luspatercept. How about hypomethylating agents, oral hypomethylating agents? This is a study by Dr. Garcia Manero presented at EHA, looking at oral azacitidine, which, as you well know, approved for AML. This was a little bit different schedule of doing 3 weeks of the oral azacitidine. They put patients on this study that were considered a higher risk of the lower risk group by having a thrombocytopenia. So this, again, was a lower risk group MDS patients, but with thrombocytopenia less than 75. The bottom line, 1/3 of the patients became transfusion independent. However, with that regimen of 3 weeks, unfortunately, there was a high grade of neutropenia, febrile neutropenia, and early death that the study was discontinued in that population. So I think we still have to figure the dosing of the oral hypomethylating agents in lower risk MDS patients. We've published before on our experience with an abbreviated course of the hypomethylating agent sub-Q or IV with AZA or decitabine 3-day regimen, showing comparable efficacy to the historical 5 days that's commonly used in the USA. And we just finished a randomized clinical trial looking at 5 days AZA versus 3 days AZA versus 3 days decitabine in the lower risk MDS patients. As I mentioned, I typically use hypomethylating agents in the lower risk only if patients have concomitant thrombocytopenia or neutropenia, or if they have really higher risk features. So moving to the higher risk MDS, I think this remains our algorithm. Allogeneic stem cell transplant is still probably the only curative option for our patients. And in patients with higher risk, we favor moving forward to transplant early on in the disease. Typically, we do start hypomethylating agents among those patients. If there is a donor, we subsequently go to transplant. If there is no donor or patients are not fit for intensive chemotherapy for allogeneic transplant, then we continue hypomethylating agents. And after HMA failure and higher risk is really an area of unmet need, where clinical trials or if patients were able to proceed to transplant are probably the best options we can offer those patients. Now, we also, in addition to the luspatercept, this year in the United States, we got approval of oral decitabine. So this is what we call, the drug name is Inqovi, which has cedazuridine, which is an inhibitor of the CD to the stabilization of the decitabine, and it will not be degraded by the gut CDA. The study originally looked at bioequivalency, where the design looked at having patients receive the first cycle of oral versus decitabine and then cross. This was really an elegant design to look at the bioequivalence. And what it showed, basically, it's almost 100% bioequivalent to the IV decitabine. And the preliminary results, and those were updated later on by Dr. Garcia Manero as well this year, shows that the efficacy is really very similar to IV decitabine. So oral decitabine now is an option for patients in the USA with a higher risk disease. It's important to notice that oral azacitidine that's approved for AML is different. The pharmacokinetics and dynamics with the oral azacitidine are not equivalent to the subcutaneous azacitidine. So we don't use azacitidine outside clinical trials in MDS, while oral decitabine seems to be similar. There is another oral azacitidine from the same company, Astex, is being in development also in MDS. Now, as you know, hypomethylating agents have been the standard for higher risk MDS, but we are trying to improve that bar. What we expect with hypomethylating agents in higher risk MDS in real life is around 50% overall response, less than 20% complete remissions, and a median survival in real life somewhere between year to year and a half. The original AZA001 study that led to the azacitidine approval for higher risk demonstrated a 24-month or 2-year survival that we have never been able to replicate in real life. So what we expect is somewhere around year and a half, around 50% overall responses and 20% CR. So clearly we need to improve that bar. So there are several promising combination therapies upfront in addition to azacitidine. Magrolimab is a drug that targets CD47. CD47 is a receptor expressed in cells. We call it the don't eat me signal. So it blocks the macrophages eating or evading those cells. And it tends to be overexpressed in patients with MDS and AML. Dr. Davar, I think, alluded to this in his presentation as well. So the idea as we block CD47 will allow the macrophages as checkpoint inhibitor, almost immune checkpoint inhibitor, to engulf the leukemia cells. So we've been conducting a phase 1, phase 2 study that we've led in the country, looking at magrolimab azacitidine that included both MDS AML. As you can see, those are highly risk group of patients, majority having poor risk cytogenetics, enriched by therapy-related MDS, very high risk revised IPSS, and subset of those patients, particularly the AML group, having p53 mutation. And so far, we've seen promising results with overall responses approaching around 90%, and the complete response rate more than 50%. And interestingly, around 1/3 of the patients achieving complete cytogenetic response, and a subset of patients also becoming MRD negative with this treatment. What's important also that it seems that the magrolimab is agonistic of somatic mutations, that we see good results in patients with p53 mutation, and this is true both in MDS and AML. This was updated again this year with a larger cohort in the AML than what I'm showing here, but showing same results, high response rates even in patients with p53, and looking more durable than the historical data with p53. In terms of side effects, treatment is very well tolerated in general. There is on-target hemolysis with the first dosing. CD47 is expressed on the red blood cells. So as we treat patients with the first round, we do see on-target hemolysis that subsequently will subside. But if the patients had interruption in their treatment, then we'll have to re-escalate the dosing because this hemolytic anemia will be observed. Other than that, treatment is really well tolerated. This is moving forward in a phase 3 trial currently ongoing, and it's also moving in a phase 3 trial in AML for patients with p53, where there is a randomization between AZA venetoclax versus AZA magrolimab in that p53 mutant AML population. So again, p53 mutant MDS or AML, as you know, is the Achilles heel, Achilles tendon in myeloid diseases with poor outcome. Those patients unfortunately have 4 to 6 month survival. If they proceed to transplant with detectable p53, the median survival or the chances of relapse are more than probably 80% in the first year. So this is really the mother of unmet needs in myeloid diseases. As I showed you, magrolimab is showing promising results. When you look at the data with AZA-VEN in AML, unfortunately, the p53 is probably the group that did not perform well, although the response rates were high. However, the relapse and the survival was poor, with 4 to 5 month overall survival among those patients. So we clearly need more drugs. One of the drugs we've been working at called APR-246. This is a drug that binds p53 and it restores the wild function of the mutant p53. We tested this originally in phase 1 and subsequently in phase 2, and our colleagues also in France were conducting similar study. Both of those studies now are published in JCO. This looked at patients with MDS or AML, particularly p53 mutant. Again, you see here very high risk group with complex karyotype as expected, and enriched with therapy-related MDS as well. Again, we observed high response rates, complete responses more than 50%. And when we look at the survival, again, compared to the historical of 4 to 6 months, we see around 10 months overall survival. And particularly among those patients that cleared the p53 and proceeded to transplant, we see a median survival around 14 months in that group. Treatment is well tolerated. There is some neurological toxicity observed that's usually reversible: perioral numbness, dizziness, imbalance. Was more reported with the French group, but mostly reversible. No excessive myelosuppression. So this is finished a phase 3 trial that unfortunately the press release at the preliminary look at the data did not confirm the higher responses with the combination, but we are looking further at the data to try to understand if there is a subset of patients that drove survival benefit from this treatment. Pevindostat is another drug we are looking at. This is an edylation inhibitor that was tested years ago in AML, showing some activity, and now have finished a phase 2 trial and undergoing a phase 3 trial in MDS. This is the phase 2 trial presented by Dr. Adas at ASCO, EHA, and most recently by Dr. Sekeres at ASH, where they took patients with higher risk MDS, oligoblastic AML, and higher risk CMML, randomized them between pevindostat, AZA versus AZA. And the study primary endpoint was event-free survival in terms of death and AML transformation. Secondary endpoint was overall survival. And the study included, as I mentioned, a group of CMML patients, lower risk or low blastic AML, as well as high risk MDS. When we focus at the patients with higher risk MDS, the study met the primary endpoint of better event-free survival, as shown here, as well as a trend for improved overall survival. There was no clear benefit in patients with CMML particularly, so the study is moving into a phase 3, focusing on with higher risk MDS. In terms of tolerability, the treatment is tolerated, again, very well tolerated. No additive toxicity almost to hypomethylating agents, which makes it as an appealing agent to add to triplet combinations in the future. And here I'm showing the response rates, again, doubling of the CR rates compared to the azacitidine as well. Just briefly covering venetoclax, because I'm sure you heard a lot about this in AML. In MDS, this is data presented by Dr. Wee. There is an ongoing randomized trial with overall survival goal in MDS. First, the dosing of venetoclax in MDS is only 14 days, contrary to the AML. In the upfront setting, it shows promising results with overall CR, CRH probably approaching 60%. The slide is not showing here. The main thing, if obviously like in AML, is the myelosuppression, needing to reevaluate bone marrow after the first round, and those adjusting the venetoclax in the subsequent cycles. So we are awaiting the final results of the phase 3 in MDS patients, but as I mentioned, the scheduling is different in MDS. And Dr. Zidan also explored use of add-back strategy, adding venetoclax to hypomethylating agents. We also published our experience with this approach, along with our colleagues from Memorial Sloan Kettering. So those are patients had prior exposure to hypomethylating agents or failure. Venetoclax as single agent really has modest activity, if any, but in the add-back strategy, there is around 20 to 30% overall responses seen I regard this many times as a bridge to transplant in patients that relapse after hypomethylating agents. Our approach had been, if there are no clinical trials and patients are not candidates for intensive chemotherapy, is shifting the hypomethylating agents and adding venetoclax as an attempt of a bridge to transplant. It actually has some promising survival data compared to the historical 4 to 6 month overall survival in patients after HMA failure. There are several other drugs to discuss, but in respect of the time, and I'm probably already running beyond the time, I'm just going to mention a few things. Sabatolimab is a drug that targets TIM receptor. This is a very exciting target because it targets both the T cells, or engage the T cells, and targets the leukemia stem cells. Phase 1 data in MDS had been presented showing some promising signal and durable responses. So it's moving into phase 2 and phase 3. IDH1, IDH2 inhibitors, as you know, approved for AML, are looked at as single agent after HMA failure. We have studies moving CPX351 that's approved for AML to be used in patients with MDS that have more than 10% blast as an induction strategy prior to transplant compared to hypomethylating agents. And finally, in the lower risk MDS, roxadustat that targets the HIF pathway is a drug that have shown in phase 1, phase 2, 30 to 40% transfusion independency. Roxadustat is approved in some countries for anemia of renal failure, and this is now in phase 3 in lower risk MDS. So I think this is kind of my hope or vision down the road in the higher risk MDS, that the first time we are having some combination therapies with high response rates, that we can start looking at, a concept of total therapy in higher risk MDS. Treatment backbones hopefully will be doublets or triplets. We will be able to achieve CR, and maybe patients that achieve MRD negativity will start looking at value of transplant, value of maintenance. In patients that MRD positive, again, looking at value of transplant. We are already designing studies looking at potential discontinuation of therapy in patients with MRD negativity in the future. So hopefully this is not going to be just a dream and will be reality, at least in clinical trials in the near future. With that, I think I'll stop. This is my email. Again, please feel free to email me anytime with any question. And it's really a pleasure to be part of this meeting. Thank you very much.
Thank you, Dr. Kambrokji, for this excellent presentation. It's my honor now to present Dr. Brentwood. Dr. Brentwood is a professor of laboratory medicine at the University of Southern California. He is the director as well of hematopathology at Children's Hospital in Los Angeles. His research is mainly focused on laboratory monitoring of clinical response in acute leukemia and biology of acute leukemia. Without further ado, I will leave the floor to Dr. Brentwood.
Thank you very much for that kind introduction, and it's a pleasure to be with you today to talk about minimal residual disease detection, both by flow cytometry and by molecular methods, very briefly. Could I have the next slide, please? So minimal residual disease detection, or now we call it measurable residual disease detection, is a technique that attempts to determine a patient's eventual prognosis based on testing early after therapy. We know that in patients with leukemia at the time of diagnosis, there are very large numbers of abnormal leukemic cells or blasts that circulate in the blood and within the bone marrow. And following initial therapy, the number of those leukemic cells hopefully will decrease in number. In some patients, this happens relatively rapidly, and it's relatively common for them to reach a point where one cannot detect the leukemic cells at any level, regardless of the technology that's used, as is shown on the left. In other patients, the response may be somewhat slower, and in some patients, they will retain the presence of residual leukemic cells for some time after therapy. And those patients we know have a somewhat higher incidence of relapse. And so the intent of this kind of testing is to observe both the initial kinetics of response to initial therapy, in other words, how rapidly the leukemic cells disappear from the blood and bone marrow, as well as the eventual nadir or lowest point at which they achieve remission, as an indication of the eventual potential outcome for these patients. Hopefully, by identification of residual disease early after therapy, one can intervene in those patients that appear to have a worse outcome because of the presence of residual disease and institute changes in therapy that then result in an eventual better outcome for those patients. Next, please. So there are a couple of basic ways in which we can detect residual disease. The first is looking at the presence of abnormalities in protein expression or antigenic abnormalities. Protein expression is governed by underlying genetic process that's very tightly regulated, so that in patients that undergo mutations that eventually result in what we recognize as leukemia, it results in secondary alterations in protein expression as a reflection of the underlying genetic abnormalities. In a sense, the changes in protein expression integrate the effect of all the molecular abnormalities that have accumulated in a given cell. So by looking for the presence of these antigenic or protein-based abnormalities, we can identify and distinguish abnormal or leukemic cells from normal cells of similar type that are present in blood and bone marrow. And we'll talk about the way in which we do this in a little more detail. The other way to approach this problem is to look for the presence of molecular mutations. In other words, go right to the source where we know cancer originates based on the presence of specific molecular mutations. The problem, particularly in AML, is that there's no single target of which to design an assay. There's a wide range of different types of mutations that have been described, as you'll see a little bit later. And so single assays can't really be developed except for small subgroups of patients. Currently, those include patients with APL that have the 1517 translocation, patients with the 821 translocation, NPM1 mutation, etc. Hence, to date, most of these assays have been PCR-based assays looking at single genes. However, with the advent of next-generation sequencing or high-throughput sequencing technology that's capable of high-level multiplexed evaluation of genetic loci, we're able to design multiplexed assays that are capable of looking at multiple different targets at the same time. And those types of assays are now in validation for use as MRD measurements in AML. Next slide. Next, please. So if we talk a little bit more about flow cytometry, the basic method that we use for immunophenotyping by flow cytometry is based on a relatively simple principle, and that is that normal populations of cells express proteins or antigens in a consistent and reproducible pattern with maturation that's essentially invariant between individuals, regardless of their age, sex, race, etc. And so this serves as the reference point for understanding what normal maturation looks like and providing the ability to then identify populations of cells that deviate from normal maturation as a result of underlying genetic mutation. When this happens, the underlying patterns of abnormality in neoplastic cells can be quite varied. There can be increases or decreases in the expression of antigens normally expressed by a given cell type. There can be changes in the timing of expression, in other words, the relationship between antigens during the maturational process, so-called asynchronous maturational expression, where immature antigens are expressed on more mature populations of cells or vice versa. There can be, frankly, aberrant antigens expressed that would never be expressed by a given cell type, and this is great when that happens, but it's actually not the most frequent thing that happens. And for populations that are normally more variable or heterogeneous in the expression of a set of proteins, then we become much more homogeneous or uniform, reflecting the underlying clonal nature of the expansion in leukemia. So basically what we're looking for are populations of cells of a particular lineage at a particular maturational stage that look different from what we understand normal maturation to represent. Next slide, please. So what this implies is that one of the most important things is to understand what normal looks like so that we can then identify abnormal. And so the area where this was first employed and continues to be kind of the front runner in the application of MRD is in B-cell neoplasms. So if we look at normal B-cell maturation, we have a variety of different maturational stages across the top and a variety of different antigens that are commonly looked at in B-cell malignancies on the left. And at each of these stages of maturation, we can map out the expression patterns of each of those antigens and develop a maturational map that describes the expression of those antigens along the maturational process for B-cell maturation. So on the left, for immature early B cells, these express TDT in the nucleus, CD34 on the cell surface, a high level of CD10, along with the lineage-specific antigen CD19. As they move to the next stage of maturation, here called immature mid, TDT and CD34 are lost, CD10 expression declines, CD19 expression goes up, etc. And so by building an appropriate panel of antibody reagents, we can identify not only that these are B cells, but we can identify the maturational stage at which those B cells most closely correspond, and simply ask the question, is the pattern of expression of all of these antigens meeting expectation? In other words, is it normal or not? Next, please. So this is an example of where we've operationalized such a panel of reagents. And so this is an 8-color flow cytometric experiment done many years ago, and looking just at CD19 positive B cells. And what we can tell is that the relationships of the expression for each of these antigens is not random, that they cluster very tightly into discrete groups of cells along a maturational pathway. So that first early stage of B cell development I mentioned is in yellow. They express CD10 at a high level, CD45 at a low level, and as they mature to the next stage of maturation in light blue, CD10 expression goes down, CD45 expression goes up, etc. And so this represents our understanding of normal B cell development and serves as our reference point. Next. However, the other thing that we need to include in such panels of reagents are reagents which are commonly aberrantly expressed, or proteins that are commonly aberrantly expressed in a given type of leukemia. So it's not enough just to know what normal looks like. We need to have some idea as what could potentially be abnormal as well. So one can then survey a variety of different antigens that are of interest, as this group has, and they're indicated on the left, and catalog how frequently a given antigen is abnormal in this case, B lymphoblastic leukemia. What one quickly sees is that at the top, CD38 is very commonly abnormally expressed in B-ALL. So this would be a useful antigen potentially to include in panels for residual disease assessment. Whereas antigens like CD21 or CD22, which are commonly expressed on B cells normally, are not abnormally expressed very commonly in B-ALL, and as a result, are probably not as useful, at least for the purpose of residual disease monitoring. So between mapping normal maturation with an appropriate panel of reagents and including reagents which we know are commonly abnormal for this disease, we can construct a panel of reagents. Next. So here's an example of such a panel of reagents that's been employed on this patient, which happens to be a medical student that developed B-ALL at our institution and was treated with bone marrow transplantation ultimately, and this is the bone marrow post-bone marrow transplant sample. So we're looking at CD19 positive B cells, and in the top row, second from the left, you can see CD10 versus CD20. Normal immature B cells are in light blue, normal mature B cells are in dark blue, and there's a population of cells in red, which is different from any of those normal populations. It expresses an abnormally high level of CD10, also co-expresses CD20 in a way that's not normal for B cells. CD58 on the next panel over is increased in intensity relative to normal immature B cells. CD38 in this patient is relatively normal on the bottom left, but CD45 on the bottom second from left is completely negative on the population of interest in red compared to normal immature B cells in light blue. And on the far right bottom, the population expresses CD34, but at a level that's slightly lower than that of the normal counterpart, which is seen just below it in light blue. So that population of cells in red has an overall immunophenotype that's most reminiscent of the first early stage of B cell development, or stage 1 hematogones, but exhibits important immunophenotypic differences that allow us to identify it as abnormal, even at relatively low levels, in this case at a level of 0.1%, which is not unusually low these days. Nevertheless, serves as a relatively straightforward way for B lineage neoplasms to identify the presence of residual disease. Next. So these are the panels of reagents which we have employed for over a decade in clinical trials with the Children's Oncology Group, where we serve as a central reference laboratory for MRD testing. On the top is a relatively simple 2-tube, 6-color assay that works very well for the identification of residual disease at early time points after therapy, such as end of induction. It wasn't designed to detect MRD in the presence of large numbers of normal B-cell precursors later from therapy. Additional reagents could be incorporated into this, and there are versions of this that we've been testing. But for early identification of MRD, this is a very straightforward exercise now, and we've qualified over 30 laboratories around the world in order to do this type of testing for our clinical trials using that assay. In teen lineage ALL, this is a much rarer disease. We serve as the central reference laboratory for the studies for COG, but it's still a 2-tube assay in about a 9-color format that works very well for identifying residual disease in T-ALL on these clinical trials using a very similar approach to what I've described, but with obviously a different set of antigens. Next. So what about AML? AML is a much more complex problem. The same principles can be employed, but we're talking now about a variety of different maturational stages for early progenitors as they mature in bone marrow. This is in part because the way we've defined AML is very heterogeneous and encompasses a wide variety of different entities, including leukemias that have a stem cell-like characteristic to them, as well as leukemias that have a more lineage-committed immunophenotype along many different lineages, including neutrophilic, monocytic, erythroid, plasmacytoid dendritic cell, etc. And so as a result, the panels are going to be inherently more complex, and the maturational patterns that one needs to understand are also likewise more complex. Also, we don't have simple lineage-associated antigens that we can use like we have in B or T lymphoblastic leukemia as a starting point. So in B-ALL, we often use CD19 or perhaps CD22 or 24 as B-cell associated antigens. In AML, because we're talking about cells that in some cases are even not committed to a lineage, they're hematopoietic stem cells, we need a different kind of a starting point or approach. So a common way to do this is to look at CD45, an antigen expressed on all white cells at varying levels, dependent on maturational stage, versus light scatter or side scatter. And here we have two representations of that, linear side scatter on the right, logarithmic side scatter on the left. And the progenitor populations of cells in this type of display lie in the gates or boxes that are indicated. So by focusing our attention in this area and excluding the events outside of this region, we can remove a large number of the relatively more mature cells that are very unlikely to represent leukemia and focus our attention on early stages of maturation within normal bone marrow and blood. Next. So this is an example then looking at that progenitor area on 45 side scatter using a variety of different antigens in a 10-color experiment that we did many years ago. We were the first to develop 10-color flow cytometry and implement this in a clinical laboratory. And we're essentially using the same approach as what I described for B-ALL, except now we're looking at different maturational stages with a different set of antigens. But the idea is the same, to map normal maturation and look for things that deviate from that as a marker of disease. So on the bottom row, third from the left, we have CD34 versus CD38, and what is circled are the hematopoietic stem cells having a level of expression of 34 that's relatively high, and CD38 that's relatively variable and low. That subset of cells is biologically very important in AML. Many AMLs contain subsets of cells that have similar types of immunophenotypes that are often referred to as the leukemic stem cell. And the normal counterpart has a well-defined immunophenotype that one can learn. Bottom row on the left, we have early erythroid differentiation with the increased expression of CD71, the transferrin receptor, so we can uniquely and early identify erythroid populations as they mature from those committed stem cells. Middle row on the far right, CD19 and CD34 can identify the early stages of B-cell development and identify them in a specific way. And in the middle row on the left, CD13 and CD15 can be used to distinguish promyelocytes in green at the top, having a high level of 13 with co-expression of 15, and early monocytes below that having CD15 expression, but with a lower level of CD13. In essence, we're going through and mapping discrete stages of maturation along what is the continuum and learning what the immunophenotypes are as the cells move from hematopoietic stem cells to each of the major lineage-committed components. Next. So if we focused on a specific subset, such as normal CD34 positive progenitors, we could break them down into two very basic groups, the hematopoietic stem cells, which are colored orange or yellow here, and the lineage committed progenitors that we've colored red. And so the stem cell population, you can see, has a very defined phenotype with the expression of 34 at a high level, 38 at a relatively lower level. CD117 or c-KIT is expressed, but at a level lower than that of the mature forms in red. CD13 is expressed, as is CD33, but at lower levels. HLA-DR is expressed at a lower level. CD123, the interleukin-3 receptor alpha chain, is expressed at a low level. And CD45, kind of paradoxically, is expressed at a slightly higher level than that of the lineage-committed progenitors in red. So this defines what normal hematopoietic stem cells look like. Next. But similar to what we did in B-ALL, we need to understand what is commonly abnormal in AML. And so surveys have been done of large numbers of antigens, in this case 1,400 patients with AML from the group in Germany, and cataloging the different kinds of abnormalities that are seen, which are of a much more complex nature, just because of the complexity of the populations we're dealing with. But in general, what's been found is that the large majority of patients, between 80 and 95% of patients, have on average 2 to 3 different kinds of immunophenotypic abnormalities or leukemia-associated immunophenotypes that can be seen in each patient. And so it suggests that it is possible to use this technology to identify abnormal populations for MRD detection. Next. As I alluded to, AML is a little bit unique in distinguishing it from B and T lineage leukemias, in that it has a hematopoietic stem cell-like component. And this is important to look at and monitor in these types of assays because they very commonly show immunophenotypic abnormality and are probably biologically important as a reservoir for eventual relapse. And so on the bottom, we have the normal pattern of expression on CD34 positive progenitors, looking at CD38 variably low leukemic stem cells. And normally these populations do not express antigens like CD7, 11B, 2, or 56, which are commonly seen in other lineages, such as NK cells, T cells, or early myelomonocytic forms. However, in AML, those same types of populations that express both CD34 and have variably lower CD38 on the top row can abnormally express these antigens, CD7 on the left, CD56 on the right, etc. And so it's useful to look at these antigens just practically in order to assess for residual disease, but also because these are potentially biologically relevant. Next. In addition to these types of antigens that have been described, there are a variety of other antigens which can also be looked at on stem cells as potential leukemic markers. And I apologize, it looks like the boxes here have become dissociated from the actual populations. But we've surveyed these, as have other groups, and you can see a variety of these different types of antigens and their expression patterns on myeloid stem cell neoplasms. And the take-home message is that there is a lot of variability, that almost all of these antigens show a subpopulation of AML or a stem cell disorder in which they're abnormally expressed, but they're not uniformly abnormally expressed on all patients. And so there's no magic bullet of a single antigen that one can use to assess all patients for residual disease all of the time. It's going to take, again, a much larger panel of reagents in order to do this work effectively. Next. So this is the panel that we constructed over 10 to 15 years ago and have validated extensively and published in the literature in many different trials for looking at AML MRD by flow cytometry, in which we continue to employ in clinical trials with some further modification. So the top row, labeled 1, is a combination that's designed to look at hematopoietic stem cells as they mature from these stem cells to each of the major lineages in marrow. It includes some of the more common myeloid-associated antigens like CD13, 33, and 117. It uses a backbone of CD45 to use in conjunction with side scatter to identify progenitors, and CD34 and 38 to allow identification of these early stages of development. The second tube is focused more on later stages of maturation from those committed progenitors to each of the major lineages of myelomonocytic maturation in particular, and includes antigens like CD64, CD123, and DR to identify specifically basophils, plasmacytoid dendritic cells, early monocytic differentiation, etc. And the third tube is focused on identifying the common aberrancies of CD56, 7, and 5 expression on these early progenitors in AML. So the panel focuses on identifying normal maturation, but also includes antigens that we know are commonly abnormal in AML. Next. And this is an example of what MRD and AML can look like. So this is a small subset of the overall data that we would look at in such an example, but this is a patient following induction chemotherapy. On the top left, we have CD34 and 38. We can see our normal pattern of maturation with the normal 34 positive progenitors in red that then mature and start expressing lineage-associated antigens with an intermediate level of CD38 kind of on the right. And there's a population of cells colored orange-yellow that has a higher level of CD34 than any of those stages and a slightly lower level of CD38. That is an abnormal population that shouldn't be present in this type of sample. On the top right, this population also expresses HLA-DR at a variably decreased level compared to normal, but with a lot of variation. On the bottom left, CD33 and 34 are overexpressed at a high level and different from normal. And on the bottom right, CD56 in particular is overexpressed to a high degree. It makes it relatively easy to identify this particular abnormal population of cells. So we've identified a discrete population of cells that has an immunophenotype different from any normal stage of maturation and consistent with the presence of residual leukemia. Now, this is an example used for illustration. Not all cases are as simple or straightforward as what I'm indicating here, but nevertheless serves as an illustration of how this approach works in AML, similar to what we saw in B lymphoblastic leukemia. Next. So let's look at a simple case just to see how this kind of works and emphasize a particular point. Here we have a 66-year-old male with a 1-month history of fatigue and pancytopenia. Next. And at diagnosis, we have the population in red, which represents the patient's leukemic population. So this patient has AML, the blasts or leukemic cells are in red. They have a low level of CD34 with low CD38, a high level of 117 with a little bit of CD15, and express 13 and 33. 1 or 2 weeks after therapy at day 16, we still have residual disease pictured in red. The population still abnormally expresses CD34 and CD38, although you can start to see normal stem cells in the background that have a little bit more CD38 and higher 34. But look at CD117. It's virtually absent on this population, which was very positive at the time of diagnosis. And there's more CD15 expression than was seen at diagnosis. Also notice 13 and 33. CD33 and 13 are now almost negative, very dimly expressed in comparison to the more robust expression seen at diagnosis. A month after therapy, the population of cells now is still present with normal maturation in the background, but those same phenotypic changes persist. So the point here is that there have been significant changes in the expression pattern of these antigens after therapy. And so one can't rely on the initial diagnostic immunophenotype to identify residual disease after therapy, even though it may be very useful to kind of point you in the right direction. Next. Next, please. Could I have the next slide, please? Hello? Next, please. Thank you. So if we look at these populations and simply ask the question, what is the least necessary information that we need to distinguish normal from abnormal cell populations? Is it the use of informative antibody combinations, knowing the pretreatment immunophenotype of the neoplastic cell, knowing normal patterns of maturational expression, or having an experienced interpreter? Well, A, C, and D are all necessary in order to perform this type of work. Otherwise, this approach doesn't work. It's B that really is the least important. We don't really need to know the pretreatment immunophenotype in order to identify the presence of abnormal neoplastic cells if we know what normal looks like and are using an informative antibody combination. Go to the next slide, please. And so if one looks at the overall workflow for MRD identification, based on this type of thinking, on a pretreatment sample, we like to run flow cytometry to identify the types of abnormalities that are present on the given patient's leukemic cells. These are often called the leukemia-associated immunophenotype, or LAIP. Post-therapy, we'll use the same panel of reagents to identify populations that are different from normal, but there are two basic schools of thought or workflows that are often used to do this. One of them is the so-called difference from normal approach, which is essentially what I've been advocating, which is that we identify discrete populations of cells defined by multiparametric gating or analysis, and we use the pretreatment immunophenotype as a starting point, but don't rely on it exclusively. The other approach that's been commonly used, particularly in Europe, is the so-called leukemia-associated immunophenotype, or LAIP approach, where a gate is defined on the pretreatment sample in a defined area where normally there are very few normal cells, but is present in the patient's leukemia. And then after therapy, the same panel is run and events are simply enumerated in that area as evidence of residual disease. What this approach assumes is that there is stability of the leukemic immunophenotype after therapy, and I've shown you one example where that's not the case, and as well, the background populations of cells are normal after therapy in comparison to resting bone marrow often, which also may not be the case. So as a result, people that use this approach advocate looking at multiple different immunophenotypic abnormalities at the same time, when possible, to mitigate these types of problems. The challenge is that you then end up with different types of populations being identified that have to be cross-correlated to determine what the actual level of MRD might be. And so often, just the highest level is what's selected. Now, there's an ability to harmonize these two approaches by allowing some flexibility in gating of the populations of cells. And for those of us working on consensus type of protocols for this purpose, that's the area that's being explored. Next. So here's an example from the literature showing in the middle row a leukemic immunophenotype on the far left at the time of diagnosis, and after therapy at progressive time points, the persistent presence of events still within that box, and the patient eventually relapses on the far right. On the bottom row, we also have, at the time of initial diagnosis, an abnormal immunophenotype that's been identified, the box is drawn, and after therapy, the number of events in that area progressively decline after therapy, and the patient remains in remission. So this approach does work for a subset of patients, but there are the caveats that I've mentioned. Next. And one of those is shown here in the published paper, where we have on the left 4 dot plots in red the example of leukemic population that was identified. And you can see on the bottom row in second from the left that the population of cells in red really represents about half of a population of cells, part of which is also colored green. And so they're bisecting or dividing in half a single population of events and calling this an LAIP, an abnormal immunophenotype. On the right series of dot plots after therapy, that same analysis set of gates was used, and they identify residual disease. But notice in the top row far right, the population of events that's being identified does not look like a single population, and instead looks like the trail of normal distributions that happen to be falling into that area. These are probably just the outlying edges of normal distributions of cells and probably do not represent MRD. And so this approach doesn't really focus on identifying populations so much as just identifying events that fall within a given area or space that was defined on pretreatment samples. And as a result, is prone to problems both in terms of sensitivity and specificity for subsets of patients. Next.
Thank you, Dr. Wood. You have 1 minute remaining.
Thank you. And so if one looks at the frequency with which one sees these kinds of immunophenotypic changes, it's actually relatively common in AML. In fact, in this one early study using a somewhat simpler technology, they found that 91% of patients had some degree of immunophenotypic change after therapy that resulted in an inability to identify the leukemic population after therapy in somewhere between 2/3 and 90% of the cases. With more modern approaches, this has probably been reduced to some degree, but nevertheless emphasizes that there is a high degree of phenotypic change that occurs after therapy in AML. And so as a result, one can't rely exclusively on the pretreatment immunophenotype to identify populations of residual disease after therapy. Next. So case study number 2, we have a patient who had MDS who progressed over time to develop a frank AML with the accumulation of genetic mutations that included the NPM1 mutation. Next. And so pre-transplant, we evaluated this patient, a large leukemic population of cells in red, and an immunophenotype that's very characteristic of the NPM1 mutation, which was also found by next-generation sequencing at about 23%. Post-transplant, day 28, the marrow looks much more normal, with that population essentially not being detected by flow cytometry, but the NPM1 mutation was detected by molecular studies at a level of about 0.007%. So next. What does this mean? Is this patient likely to go into long-term remission? Are they going to relapse early after transplant, or perhaps immediately after transplant, or maybe they're already in relapse based on the NGS result? Next. Well, this is what happened to the patient. Day 56, that same population of cells now begins to make a reappearance by flow cytometry at a level of about 0.03%. The level seen by next-generation sequencing is also now increasing to 0.012%. By day 84, the population is expanded by both flow and next-generation sequencing. The patient is headed towards early relapse. Next slide.
Okay.
And so this is the data that we published looking at patients' MRD levels both before and after transplant and what the relationship might be to eventual outcome. And what one can see is that the only patients that did relatively well in this analysis were patients where there was no residual disease detected going into bone marrow transplant and that remained negative for residual disease after transplant. Everyone else did relatively poorly. Patients that had no evidence of MRD going into transplant, but who developed MRD after transplant were a horrible group. They're on the far left because they're basically relapsing through transplant. And if you detected MRD going into transplant, it didn't matter what happened after transplant, you had a horrible outcome. So the pre-transplant MRD was actually the most predictive of the eventual outcome for patients with AML related to bone marrow transplantation. Just emphasizing that it's unclear exactly what transplantation is doing in this particular context, at least as employed here, but nevertheless, demonstrating that a patient is in remission and that it's sustained following therapy is very important in identifying the subset of patients that have a good clinical outcome. So with that, I would like to stop the presentation at this point.
Dr. Wood, for your presentation. I believe we're running out of time. Thank you, Dr. Wood. That was an excellent presentation. Thanks for coming here with us. And now we'll start. It's my honor to present the next presenter. Is Dr. Contagion. Dr. Contagion is the professor and chair of Department of Leukemia at University of Texas MD Anderson Cancer Center. He's also the Samsung Distinguished Leukemia Chair in Cancer Medicine. His research focused on translational and clinical development therapeutics in leukemia. So without further ado, Dr. Contagion, you can present your presentation. Thank you.
Five, four, three. Thank you for the honor of the invitation. I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center, and I'm going to update you about what we're doing today in acute myeloid leukemia at our institution. As you know, in acute myeloid leukemia, deciphering the genomic landscape has allowed us to investigate prognostic factors, but also to develop targeted therapies. Here you see that FLT3 mutations occur in a third of the patients, and now we have FLT3 inhibitors that could help them. but also IDH mutations occur in about 20%, and here's where IDH inhibitors could work effectively. So this is how we apply today the molecular studies to the treatment of patients with FLT3 mutations. We add a FLT3 inhibitor, and the favorite one is gilteritinib at our institution because it's a third generation more effective FLT3 inhibitor. For the IDH mutations, you can add either ivosidenib for the IDH1 mutations or enasidenib for IDH2 mutations. Among patients with NPM1 mutations, they are highly sensitive to cytarabine, so we try to add the Ara-C in the setting. P53 mutations are still difficult, so we always refer them to transplantation. And then I'll show you at the end the potential role of the new menin inhibitors in patients with translocation 11q23. Since 2017, we have 9 agents that have been specifically approved for acute myeloid leukemia, and the 10th one, which is oral decitabine, approved for MDS and CMML, but which at MD Anderson we use as an alternative to the parenteral hypomethylating agents in acute myeloid leukemia. So you see on the list, the most important one is venetoclax. I think it's really a breakthrough, and I'll show you that it's not only a breakthrough for the older unfit AML, but perhaps for the younger ones. You have 2 FLT3 inhibitors which are approved, and we prefer gilteritinib, but midostaurin is also available. The next 2 are enasidenib, ivosidenib, which are the IDH inhibitors, and then the oral hypomethylating agents. And I'm going to make the point at the end that oral decitabine and azacitidine are very, very different drugs. You cannot use them interchangeably. Let's start with the most curables of the leukemia. So acute promyelocytic leukemia, as you know, we started treating them without chemotherapy since 2000, only with atraarsenic trioxide, and the addition of gemtuzumab if there's a high white cell count or if they persist to have PCR positivity 2 to 3 months in remission. And this is the data from our institution where we show that we can cure almost most of the patients with the use of atraarsenic trioxide without using chemotherapy. And this is across the board of all the age groups, and we have over 250 patients. The second highly curable category is core binding factor leukemia, so inversion 16 or translocation 821. Here we use the fludarabine high-dose Ara-C with gemtuzumab. We consolidate with fludarabine Ara-C for 3 days for 5 consolidation courses, to which we add gemtuzumab in 2 or 3 courses. In 2010, we lost the use of gemtuzumab and we replaced it with idarubicin, and the results are worse. So really, fludarabine, Ara-C, gemtuzumab, or the flag gemtuzumab is the better approach. And here I show you the data since 2010. So again, an estimated 10-year survival in excess of 80% when we use this strategy. And this slide shows that when we use the idarubicin instead of the gemtuzumab, we lost a little bit on the relapse-free survival curve. So we went back to using gemtuzumab as part of the flag regimen. Now, I mentioned that gemtuzumab is useful in APL and in core binding factor leukemia, but the French have just published in Blood that it may have a value in additional subsets, such as patients with FLT3 mutations and RAS mutations and NPM1 mutation. The problem is how to combine gemtuzumab with venetoclax, because we value venetoclax as a drug that's more useful, and we're using it in combination with intensive chemotherapy, which I'll show you next. So now we're going to come to the treatment of the other acute myeloid leukemia, so patients who do not have APL or core binding factor leukemia. And as you know, the standard that has been accepted by many for the past 50 years is a 3+7 induction, 1 high-dose consolidation, allogeneic transplantation if possible, if not, a total of 4 high-dose Ara-C consolidation and no maintenance. If you accept this as a standard of care, I am showing the results on this slide. So on the left side are the patients who are younger. At best, you can probably cure 35 to 40% of the patients. And on the right side are the older patients who can still receive 3+7. And here the cure rate is under 20%. So we can do better in the younger patients with FLAG-IDA venetoclax, as I'll show you. And we can do better in the older patients with the triple nucleoside low intensity therapy, which I'll show you at the end. So this is the data from MD Anderson. So since 2010, our estimated 5-year survival is close to 60%. And this is because we do not accept 3+7 as a standard of care. We try to do better than that. In the older unfit patients, we are improving the survival, but still we're not doing as well. And I do not show the data since 2015, where we are using the venetoclax in addition, and I'll show you the data at the end. So what do we do at MD Anderson? In the younger patients, we either use FLAG-IDA or CLIA with venetoclax. We add the FLT3 inhibitors as indicated. We still try to take the patients to transplant. If not, they receive the same intensive chemotherapy for 6 cycles, and then everybody gets a maintenance for 2 years. In the older patients, we cannot do the intensive chemotherapy, so I'll show you the regimen with the triple nucleoside analog therapy, cladribine, low-dose Ara-C, azacitidine with the addition of venetoclax. Again, we try to take them to transplant or do maintenance therapy. Now, why do I say that 3+7 is not an optimal standard of care? It's because there are now several studies that have shown that using high-dose Ara-C during the induction improves the survival. So I showed the data here and the references from the EORTC, the Chinese, the MRC, and the Italians. And the FLAG-IDA is simply fludarabine added to high-dose Ara-C during the induction. And we have taken this regimen now and added to this the venetoclax in the form of FLAG-IDA venetoclax. We reported at this ASH meeting that among the younger patients, when you use this regimen, the marrow CR rate is 90%, MRD negativity is universal, and the 12-month survival of 85%, which I show in the curve on the right side. Now, we did the same with the CLIA. So here, all we did was to replace fludarabine with cladribine, because cladribine as a single agent is effective in acute myeloid leukemia. We added the venetoclax to the CLIA, but we do it only for 7 days here because you can get into quite a bit of myelosuppression. Again, we reported at this ASH meeting in the first 30 patients that we've treated, CR rate 90%, low mortality, 12-month survival of 80%. Now, other people are doing the same. So this is a study from Italy using fludarabine, high-dose Ara-C, idarubicin. They've treated 150 patients, and they report a 3-year survival not of 35 or 40%, but of 60%. And now some of the adverse subsets like FLT3 positive is not adverse anymore. So this is the curve of the patients who are NPM mutated, FLT3 positive, and their estimated 10-year survival is 50%. So excellent results. And this is before adding the FLT3 inhibitors. Now, also, as you know, oral azacitidine is now approved as maintenance therapy for AML. This is based on a randomized study in close to 500 patients who are older and who were in first remission but could not complete the intensive chemotherapy or go to transplant. So they were randomized to oral azacitidine, which is poorly absorbable, given for 14 days, or placebo. And the oral azacitidine improved the survival of the patients. Now, there's another oral hypomethylating agent, oral decitabine. This is combined with the cytidine deaminase inhibitor, so it's 100% absorbable. And the FDA approval is not for AML. It's approved for MDS or CMML. based on 100% absorption. So when you look at the exposure, the area under the curve of the oral versus the IV, the absorption is 98%. In myelodysplastic syndrome, the overall response rate is 60%. The median survival is 18 months. And this led to the FDA approval. And at this ASH meeting, Dr. Savona updated the phase 3 trial, which was identical to the phase 2 trial in 133 patients. And this is again in MDS-CMML, overall response rate 62%. And now the median survival is in excess of 2 years because people have learned how to use the oral decitabine. So to emphasize, these are two very different drugs. The absorption of the oral decitabine is 100%. It's given at a fixed dose of 35 milligrams daily for 5 days every month. The indication is for MDS-CMML, but at MD Anderson, we started using the oral decitabine instead of the parenteral hypomethylating agents in the older unfit AML. The oral azacitidine has an absorption of only 10 to 15%. It's given for 14 days as a fixed dose of 300 milligram, and the FDA approval is in first remission AML, unable to complete the intensive chemotherapy. So next, I'm going to show you what definitely works in acute myeloid leukemia and how we're using it. So we know that FLT3 inhibitors work, IDH inhibitors work, the gemtuzumab works, venetoclax works, and I showed you also the oral hypomethylating agents. So let's start with gemtuzumab. So as you know, the meta-analysis that was conducted brought back gemtuzumab in 2017 as therapy for acute myeloid leukemia, and the approval is in combination with chemotherapy, and the best results are apparently in the core binding factor leukemias, shown on the right side, where the potential cure rate increases from 55 to 77%. But as I showed you earlier, the drug works also in FLT3 mutated AML, NRAS de novo AML, and NPM1 AML. So the challenge is to how to add the gemtuzumab to something like FLAG-IDA venetoclax, because then the myelosuppression is going to be quite significant. There are other antibodies which are being developed that target CD33 and CD123. They are in the form of antibody drug conjugates or as bispecific antibodies. And here I show the spectrum of the drugs under development. But the bottom line is none of these drugs has made it yet to an FDA approval like gemtuzumab did. Here I showed the immunogen drug. This is a CD123 antibody conjugated to alkyl benzodiazepine. And here I show the data in BPCDN. So as you know, there is a drug already approved for BPCDN, a CD123 antibody, which is conjugated to a diphtheria toxin. Here you're conjugating to a chemical toxin. And in the patients who are refractory relapse blastic plasma dendritic cell neoplasm, we're seeing a good response rate. So we think that this drug may get an approval in BPCDN, and then we can combine it with azacitidine venetoclax for the other acute myeloid leukemias. Now let's talk a little bit about the FLT3 inhibitors. So as I mentioned, the two FDA-approved ones are midostaurin, gilteritinib, but we're not using them anymore as single agents. So we're using, for example, gilteritinib with 3+7. This is an update at the ASH meeting by Dr. Prats, where 80 patients were treated with 3+7 with gilteritinib. Half of them were FLT3 mutated. On the right side is the survival curve in the patients who are only FLT3 mutated. And what you see is that the estimated 2-year survival is 70%. So one of the worst subsets of AML, FLT3 mutated AML, has become one of the more favorable ones simply because we have now an effective targeting therapy. Again, with IDH mutations, we have, as I mentioned, enasidenib and ivosidenib. And again, we're not using them in the FDA indication of single agent therapy because the benefits are modest and they are very expensive. So we started using them with chemotherapy. This is again a study that was just published in Blood online in 150 patients with newly diagnosed AML with IDH mutations who received 3+7 with an IDH inhibitor. And what you see again is that the CR rate is very high, 80 to 90%, and the estimated 2-year survival is 60 to 70%. So all those targeted therapies, FLT3 inhibitors, IDH inhibitors, venetoclax, are moving into the frontline therapy in combination with chemotherapy. Now, next, I'm going to show you what we do for patients where we cannot do the intensive chemotherapy. So these are older, unfit patients where the original studies adding venetoclax to either decitabine, azacitidine, or low-dose Ara-C showed positive results. So this led to the randomized study, which is called the VIALE-A, where patients who are older or unfit received azacitidine with placebo or azacitidine with venetoclax. This is already published in the New England Journal of Medicine, and it shows that the addition of venetoclax improves the median survival to 15 months, and the estimated 2-year survival rate is now 30 to 40%, which is very good, but it is not excellent, so we need to improve upon that. So then one may have a question, well, if I have a patient who's older, unfit, but they have an IDH mutation, should I give them azacitidine venetoclax, or should I give them azacitidine with an IDH inhibitor? And what I show in the subset analysis of the patients on VIALE-A who were IDH mutated, that venetoclax actually works very well. It improves the marrow CR rate from 28 to 60%, and it also improves the median survival up to about 2 years or beyond 2 years. So you can use the azacitidine venetoclax in older, unfit, IDH mutated AML. The next question is, what about if they are older, unfit, and have FLT3 mutated AML? Again, I showed that the azacitidine venetoclax improves the marrow CR rate from 20 to 65%, but it does not improve the survival in the FLT3 IDH mutated, which is shown in figure C. So the median survival improves only from 8.5 to 11.5 months. So this is where I think a FLT3 inhibitor like gilteritinib added to azacitidine with or without venetoclax can do better, and we have data to show that already. Now, we know now that epigenetic therapy with venetoclax is a standard of care in older unfit AML. Can we do better than this? So at our institution, we tested the decitabine 10 days with venetoclax. But when you do this, you have to worry about prolonged myelosuppression. So we always do a day 21 bone marrow, and if there's the blasts are less than 5%, we hold the venetoclax to let the counts recover. And then in remission, we use the venetoclax for only 10 to 21 days, depending on the myelosuppression. Here I show in the newly diagnosed patients, 70 patients that we treated, the marrow CR rate is as high as intensive chemotherapy in the young patients. So marrow CR rate 84%, true CR rate of 66%. The white curve shows the survival in the newly diagnosed patients. So we have improved the 1.5-year survival to beyond 40%, close to about 50%. Now, if you use venetoclax, and if you are a believer in antibiotic prophylaxis, as we do at MD Anderson, we always use posaconazole because we would like to reduce the incidence of fungal infections. This is data from France by Dr. Michalet that was already published that shows that, in fact, adding posaconazole reduces the fungal mortality, and it actually improves the CR rate from 80 to 80% with antifungal prophylaxis. because these patients, the 5 to 8% of patients who may have died from fungal infections. But if you use an azole with venetoclax, you have to reduce the venetoclax. You cannot use 400 milligrams because the azoles will increase the venetoclax plasma levels. So if you use posaconazole like we do, you reduce the venetoclax from 400 to 50 milligram, which saves you a lot of money. If you're using voriconazole, which many do, you reduce it from 400 to 100. Again, this saves you a lot of money and it makes the regimen safer. If you use 400 with an azole, you're going to get a prolonged myelosuppression and mortality. So at MD Anderson, we decided historically to treat the older unfit patients with what we call now the triple nucleoside therapy, cladribine, low-dose Ara-C alternating with azacitidine. And more recently, we added the venetoclax because it has shown the efficacy in the epigenetic therapy venetoclax regimen, which I showed you earlier. At this ASH meeting, we updated the results in about 60 patients, older, unfit for intensive chemotherapy. They received cladribine, low-dose Ara-C, venetoclax, alternating with azacitidine venetoclax. We're reporting a CR rate of 80%, true CR rates of 78%, marrow CR rates of 90%, MRD negativity of 90%, low mortality, 18-month survival of 60%. And on the right side, I showed that still whenever we take the patients to transplant, which is the blue curve, they do better than without the transplant. But even without the transplant, the 18-month survival is close to 50%. And the next slide shows the newly diagnosed, not secondary versus the secondary, just to highlight that if you have an older unfit AML who is newly diagnosed, not therapy-related, not progressing from MDS, we're getting excellent results with an estimated 1-year survival of close to 70%. So we're making progress and the results are looking very good. The last thing I want to mention relates to what I consider as a potential small breakthrough, similar to the FLT3 inhibitor and the IDH inhibitors. So for patients who have translocation 11q23, or what we call MLL leukemias, we have menin inhibitors from 2 companies. On the left side, I show the Syndax data, which was published at the AACR meeting, where patients with refractory relapse MLL acute leukemias are going into a complete remission with single agent menin inhibitors. And on the right side is another company called Cura that has shown similar results at this ASH meeting. So I think the same way as we have FLT3 and IDH inhibitors, we're going to have menin inhibitors which target the translocation 11q23, and we're going to combine those menin inhibitors with chemotherapy. Thank you for your attention, and I'm happy to answer any questions.
A21, is there MRD detection? Dr. Wood? Then I will pass the question to Dr. Kantarjan.
Can you repeat the question because I just joined in?
So in translocation 8 to 21, is there a standard level of MRD detection? Is there a standard level of MRD detection in acute myeloid leukemia?
So for the 821 translocation, we would like the PCR level to be 0 by the end of therapy. If not, we add either azacitidine, Mylotarg, venetoclax for another 6 to 12 months or consider transplant. That's not the case for inversion 16. We've seen some people with inversion 16 that have very low levels, less than 0.01%, beyond the second and third year, and they have never relapsed. So it's a bit different between translocation 821 and inversion 16.
Okay, thank you. I would ask the audience to post any questions if they have any questions. Another question, Dr. Kantarjan, can the treatment intensity reduced in patients who achieve MRD negativity after induction?
So we do not know that, but the reality is when we use the FLAG-IDA venetoclax or the CLIA venetoclax, those treatments are quite intensive. So beyond the second, third course, most of the patients start having myelosuppression, but we try to transit them to transplant always. If not, and if they cannot tolerate additional intensive chemotherapy, then we go to the maintenance, which is with either oral decitabine venetoclax for 2 years or azacitidine venetoclax for 2 years. So these things are changing very quickly now, and we're trying to catch up with this. But to answer the question, in particular, if you're using 3+7 and the patient has become MRD negative, this is a good time to do the transplantation. Otherwise, complete the 4 cycles of high-dose RC and consider maintenance with AZA or decitabine venetoclax-based therapy.
Thank you. Another question I see here from the audience: do you prefer you mentioned reducing venetoclax days. Do you prefer reducing the dose instead of days in patients with AML?
No, actually, for the low intensity, if you're using venetoclax with azacitidine, you have to do the induction for 21 days. The maintenance will be between 7 and 14 days, depending on the degree of myelosuppression. If you're using it with intensive chemotherapy, then it's only 7 days with the induction and consolidation. But we do not reduce the dose beyond 50 milligrams with cosaconazole because we have never done those studies. So the standard dose is 400 milligrams without azoles and then reduced with the azoles. But we do not reduce it further to avoid in order to shorten the number of days. There's no experience with that.
Thank you. Thank you. I see here a question. How do you approach a young fit patients with a diagnosis of FLT3 negative NPM1 positive AML after 3+7 and first consolidation with high DAC who has detectable NPM1 and who also has a full mass sibling donor? Will you go directly to a transplant or you continue to monitor them closely?
So you have to go to a transplant. On average, every time we have done the transplant versus consolidation and maintenance so far, the transplant beats the intensive chemotherapy by about 5 to 10%. So you have to go to the transplant, but because this patient is NPM1 mutated, you could consider pre-transplant AZA venetoclax to make them negative, or if you do the transplant, then consider post-transplant maintenance therapy with azacitidine venetoclax.
Thank you. Thank you. I'll see here another questions. Can patients with the prolonged cytopenia challenge MRD interpretation?
So the question here is, historically, people who have prolonged cytopenia, this was an indication for relapse, but this is not the case anymore. Now we see patients with prolonged cytopenia who are MRD negative and they are not relapsing. And that's because we're using different, more intensive therapies. We're adding the venetoclax. So if you observe prolonged cytopenia without MRD positivity, I would not worry. But this is where the possibility of the allogeneic transplantation would be of value.
Thank you. Thank you. A question to Dr. Kamrokji. Is there a dose escalation for venetoclax, and do you see tumor lysis syndrome?
So in MDS, as I mentioned, the induction phase of it is 14 days. The package insert does still say, obviously, escalation. Now, the use of venetoclax in MDS is still investigational. We use it sometimes. In our practice, we don't dose escalate. We start with the dose from the beginning, as Dr. Kantarjian has detailed in his talks, almost following that. The only difference in MDS is we do only 2 weeks with the first round. And as Dr. Kantarjian mentioned, in the subsequent cycles, you really have to cut down the dose, and if you add prophylactic antibiotics. So in our practice, we don't dose escalate. We do observe tumor lysis at the beginning, but we've not seen tumor lysis in MDS, and we do only 2 weeks in the induction.
So Dr. Shaybani, may I add a little bit, because that's a very important point. If you have a patient with AML with a high white cell count, I would cytoreduce the counts to 2,000 or less before starting the venetoclax. When we have added the venetoclax on day 1, we have seen tumor lysis and renal failure. We had several cases of renal failure, so now we delay starting the venetoclax until we have reduced the white cell count to less than 2,000. And you can do this either with hydroxyurea or with 1 dose of Ara-C. But that's a very important point in terms of the toxicity. And in those patients, we do venetoclax 20 on day 1, 50 on day 2, and then 50 on day 3 with posaconazole. And we watch for tumor lysis and renal failure because it does happen with a high tumor bulk.
Thank you. Dr. Kantarjian, another question for you. Would you consider auto versus chemotherapy as consolidation in translocation 8-21?
So that's an interesting question because, as you know, the autologous transplant is almost abandoned in the United States. It is very common practice in Europe. In Europe, what they do is they do the 3+7, 1 dose of high-dose Ara-C, and then either allogeneic or auto transplantation. Now, since we started measuring MRD better, so the historical data show that the autologous transplant may be equivalent to intensive chemotherapy for courses of high dose, but it is inferior to the allogeneic transplantation. But now that we can measure MRD to levels below 10 to the -4, one could think, well, can we use the autologous transplant now as an intensification in patients where we know they are MRD negative instead of the allogeneic transplant? And that's a question that remains investigational. Nobody has done it. The particular question of autologous transplant in core binding factor leukemias is relevant because, as the person who asked the question realized, there is data that in this setting, autologous transplant can be very effective in these patients if you can take the stem cells from the patients and prove that they are MRD negative.
Thank you. And is there any rule for venetoclax in advanced phase myeloproliferative disease?
I'm not sure that that's the case. Actually, Dr. Verstovsek always says that in the myeloproliferative disorders, it's a unique situation where there's no BCL2 overexpression, and venetoclax may not help and it may even harm. Now, he makes the point that navitoclax, which is a BCL2 BCXL inhibitor, could work in the setting of the myeloproliferative neoplasms, but that's not proven yet. So although venetoclax is helpful in CLL, in AML, in MDS, maybe in ALL, I think it is not a drug that we are ready to look at in myeloproliferative neoplasms. It may not help and it may harm a little bit.
Thank you. Another question, will you give further chemo if pre-transplant NPM1 came positive?
I think if you have a patient who is NPM1 positive by next generation sequencing or by the PCR, if you go directly to the transplant, they may do slightly worse. So you have to either consider pre-transplant additional intensive chemotherapy or azacitidine venetoclax, or consider a post-transplant maintenance.
Thank you. What about post-transplant AML relapse? Any benefit of venetoclax?
I think this is where azacitidine venetoclax has worked pretty well. So if you have a patient who relapses post-transplantation, by the way, if you have a patient who's transplanted, we're always starting to consider some maintenance after the transplantation. So if they are FLT3 positive, you add a FLT3 inhibitor, gilteritinib. If they are if you're not guided by mutations, then you may consider azacitidine venetoclax. Now, if they relapse post-transplantation, I think without any guiding mutations, decitabine 10 days venetoclax would be useful. If not, if FLAG-IDA venetoclax if they are younger patients.
Thank you. Thank you so much for Dr. Kantarjan, Dr. Wood, and Dr. Kambrokji. By this, we conclude our session. I believe next will be the virtual meeting. The virtual. Thank you all.
Thank you.
So now we can go to virtual exhibition.